This October.
Bindal madam is here now.
Ma'am, good evening, ma'am.
Good evening.
Good evening, Dr. Bindal. How are you?
Hi, Rosa. How are you? Good to see you.
Oh, Jyoti.
Hi, good evening.
Yeah,
sir.
good evening.
How are you, sir?
Good. Nice to see you.
Long time. Long
Yeah.
time no see.
Yeah.
Good evening, Jyoti madam.
Good evening. How are you?
Good evening, Jyoti ma'am.
Good evening. Sir. Nice to see all of you.
Good evening, Jyoti ma'am.
Good evening, Joseph. How are you doing?
That's fine, madam.
जी.
सुपर फास्ट ट्रेन है.
किसकी सुपर फास्ट ट्रेन है?
जयदीप सर को पूछा ना आपने.
हाँ ठीक है. जयदीप sir तो yes. And also Priyanka is going in the same direction.
These teachings. So Manila ma'am.
We are live now, sir. We are good to go, sir.
Good evening.
Good evening, everyone.
Hello, Manila.
Hello, ma'am. कैसे हैं आप?
Good, good. You okay?
Nice to see you all. Yeah, I'm good.
Shall we start, sir?
Yes, please.
So, very good evening, all respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I, Vasis Mehta, welcome you all for the Core Connect live webinar organized by Public Awareness Committee, Fogsi, in association with Chhattisgarh and Madhya Pradesh OBGY societies. Let us begin our session with virtual lamp lighting. Now, I would like to invite Dr. Priyanka Roy, sir. Sir is National Coordinator, Public Awareness Committee, Fogsi, and sir is Consultant Infertility and Gynae Endoscopy at Nova IVF and Roy's Clinic. Welcome, Dr. Priyanka Roy, sir. Over to you, sir.
Thank you so much, Vashisht. Good evening, everyone. Gives me immense pleasure in welcoming all of you to this Public Awareness Committee with the Chhattisgarh and Madhya Pradesh OBGYN Society's Core Connect program on Preserve the Uterus. As you all know, it's a very important theme, Preserve the Uterus, to, of course, prevent unnecessary hysterectomies and also for the betterment of women. So today we have the participating societies with us, the Chhattisgarh OBGYN societies, Bhilai, Bilaspur and Raipur, the president, secretaries and the members who have joined us, and also the Madhya Pradesh OBGYN societies of Bhopal, Ratlam, Gwalior, Rewa, Hosangabad, Sagar, Indore, Singrauli, Jabalpur, Ujjain and Katni societies. And I'm pleased to inform to all of you that we have representatives from all the societies who are participating in this program. So after finishing the entire of the East zone with the Preserve the Uterus program, we are now into the West zone, and this is the second last program other than Maharashtra, and we'll be finishing today's program with Madhya Pradesh and Chhattisgarh. So I would now like to welcome our chief guest, Dr. P.K. Shah sir, the guest of honors, Dr. Jyoti Bindal ma'am, Dr. Rosa Ulvai ma'am, and Dr. Archana Basir ma'am to this program for agreeing to grace the occasion. Would also like to thank Dr. Shanta Kumari ma'am, President Fogsi, Dr. Madhuri Patel ma'am, Secretary General, Dr. Basab Mukherjee, the Vice President, and of course Kalyan, who's a chairperson of the Public Awareness Committee and the backbone behind this committee, which has done wonderfully well under his leadership. We have got two stalwarts today as speakers. Dr. Jaideep Tang sir, he's going to talk to us on medical management of fibroid uterus, and the chairpersons for this session, Dr. Meena Nayak, Dr. Richa Sharma, and Dr. Supriya Jaiswal. Welcome to the program. The next speaker is Dr. Geeta Goin ma'am, and she's going to talk to us about the medical legal aspects in hysterectomy. And as chairpersons for this session, we have Dr. Nidhi Mishra, Dr. Sumitra Yadav, and Dr. Ajay Mane. So welcome all of you. We have two panels usually, the standard of this program, where we have the management of AUB in adolescent and reproductive age group, and the other panel being perimenopausal and menopausal age group. The moderators being Dr. Manoj Chellani and Dr. Sumati Premanand, who is the PSC representative here, and the expert for this panel is Dr. Sampath Kumari ma'am. The other panel, we have Dr. Asha Jain and Dr. Monica Umbertan, who is the PSC representative, and Dr. Suvarna Khadilkar ma'am as the expert. So welcome all of you. Our expert battery of panelists include Dr. Ashish Khaled, Dr. Ekika Singh, Dr. Uma Nigam, Dr. Tabassum Dalla, Dr. Mudita Jain, Dr. Urmila Tripathi, Dr. Manila Kaushal, Dr. Priyanka Tiwari, Dr. Sonal Sani, Dr. Sangeeta Raman Jogi, Dr. Kavita Babbar, Dr. Manisha Maheshwari, Dr. Jyoti Banglowala, Dr. Anjali Kanhere, Dr. Anshu Baser, Dr. Padma Shukla, Dr. Richa Paharia, and Dr. Neha Sharaf. So I welcome all of you to agreeing to be part of this wonderful program. Now to talk about the Preserve the Uterus mission, I would like to welcome our chairperson of the Public Awareness Committee, Dr. Kalyan Barmade, who is a chairperson, of course, as I've mentioned, executive council member of MSR and of AMOX. He is currently the treasurer of IAGE, and he is the convener of this program and the immediate past president of the Latur OBGYN Society. Dr. Kalyan will give us a brief about the mission Preserve the Uterus.
Thank you, Dr. Priyankur, for such a nice introduction. I'm going to take only 2 minutes. I welcome all members and esteemed guests who are present for this today's webinar. This mission, Preserve the Uterus, started in 2019. And can you see?
No, Dr. Kalyan, we were seeing it, but now it's stopped.
Somebody has stopped from your end. Okay, just wait.
Ashish?
Yes, thank you. Now it is seen.
Yeah, it's getting shared. Yeah, it's seen now. Yeah, please go ahead.
I like to thank Fogsi team, Fogsi President, Dr. Shanta Kumari ma'am, Fogsi Secretary General, and Fogsi VP, Dr. Basab Mukherjee, for this opportunity. What is mission? It is to preserve the uterus for wellness. When you talk about the role of the gynecologist, it is systemic evaluation of the patient, correct diagnosis with minimalistic attitude and non-invasive treatment, doing proper counseling of the patients, and adopting correct lines of management, and lastly, public awareness, which is very important whenever you are doing preserving the uterus. The current scenario goes back on 11th of April 2019, which was related to the Beed district of Maharashtra, where letter by Director of Health that you need to take permission before doing any hysterectomies because of the incidence of unwarranted hysterectomies in that region. And there were so many media news and reports in national as well as international papers about this. And Fogsi gave them a right reply by giving them right statistics. And I like to thank Dr. Nandita Madam, who was president that time, and Dr. Jaideep Tang, Secretary General that time, who has given them a good reply, and our stand of Fogsi that we started this mission Save the Uterus. Why were we worried about preserving the uterus? Because anytime a hysterectomy done, which is unwarranted, can cause loss of vital organ, psychological setback, physical effects, and mental health and mood changes, energy depletion, bony pains, altered pattern of sleep, diminished cognitive ability, and lastly, genitourinary symptoms, ultimately affecting intimacy and sexual life. Before going to the preserving of the uterus, we should know the common indications of hysterectomy. That is leiomyoma with symptom not responding to medications, abnormal uterine bleeding with endometrial atypia, large fast-growing atypical uterine tumors, severe adenomyosis not responding to medications, atypical endometrial hyperplasias, invasive malignancies, and uterovaginal prolapse. What should be the standard approach? We need to follow Fogsi GCPR guidelines. Fogsi has given us guidelines about everything: abnormal uterine bleeding, about screening and management of pre-invasive lesions of cervix. We need to improve on the diagnostic, that is history and clinical examination, doing TVS yourself, doing cervical screening methodology, and OPD basis endometrial biopsy wherever required. You should apply skills to treat lesions with minimalistic approach. There are innovations in pharmacotherapeutics regarding the medical management of leiomyoma as well as adenomyosis. We need to apply them in our patients. So our mission is acquiring skills in minimally invasive operative techniques, insertion of LNG IUCDs wherever required, doing hysteroscopic surgeries for polyps, submucous leiomyoma, and not doing a hysterectomy for these cases, colposcopic assessment of cervix in triage patients and treating LCL and high seal lesions with cryo or diathermy leap excision, thermal balloon ablation or endometrial resection wherever indicated, and myomectomy, either laparoscopic, abdominal, or vaginal. I like to urge all Fogsi members to go on our site, that is fogsi.org, where we have beautiful programs lined up for ultrasound training, endoscopy training, infertility training, colposcopy training, and with a very simple fee structure where 15 days or 1 month courses can be done so that we can be advanced in all treatment modalities. There are newer advances like uterine artery embolization, MR guided focus ultrasound surgery, which our speakers are going to discuss today. So what is mission preserve the uterus? Is acquire communication and counseling skills. Spend more time in explaining, answer all the queries and doubts, give time to think, and allow second opinions of your gynec colleagues, avoid medical legal battles, and follow standard guidelines. As a public awareness committee, I like to urge all societies to take at least one educational interactive seminars about preservation of the uterus in a year, and you should take webinars or seminars about menstrual hygiene facilities which are available in the big factories, because so many unnecessary hysterectomies are done because there are no adequate facilities for the women. So in practice, there are a few do's, that is follow your judgment based on objective assessment. Do not fall prey to patient's requests or relative requests or referral doctor's requests. My future speakers are going to talk about medical management. So to summarize, acquiring skills in minimal invasive operative techniques, learning insertion of LNG IUCDs wherever required, learning hysteroscopic surgeries, colposcopic assessment, thermal balloon ablation, and apply all this knowledge for ethical and litigation-free gynec practice. I thank all societies of MP and Chhattisgarh for giving us this opportunity to have this webinar on preserve the uterus. Over to Dr. Priyanka.
Thank you so much, Dr. Kalyan, for that wonderful talk and for being always there as a pillar, as a support for all the programs that that we are conducting now. So thank you so much, Dr. Kalyan. So now it gives me pleasure in introducing our chief guest. So I would request Dr. Kalyan Barmate, the chairperson of the committee, to kindly do the honors.
I'm so happy today to introduce teacher of teachers, Dr. P.K. Shah sir. was professor and unit head of Department of OBGYN at St. GS Medical College, KM Hospital, Mumbai till 2016. Past Dean of Indian College of Medical Ultrasound. Past President of IAGE, Fogsi, Indian Federation of Ultrasound in Medicine and Biology, that is IFUMB, MOGS, Mumbai Obstetric Gynec Society, AFTT, that is Association of Full-Time Teachers at KM Hospital, past Vice President of Senior Medical Teachers Association, past Vice Dean of Indian College of Medical Ultrasound, past Chairman of Imaging Science Committee of Fogsi, past Chairperson of ISOBAB West Zone. Oh, so I'm really thankful to Sir for gracing this webinar and blessing us for this webinar. Welcome, sir.
Thank you, Kalyan, for your kind words. And it's a great pleasure to be here for your project, so to say, because I know that preserve the uterus, you've been trying for past 3 years or more, maybe. And I'm sure by now you must have saved thousands of uteri. And those patients must be blessing you. So I'm really very happy that I am a part of this particular event for the first time, Kalyan. Preserve the uterus. And it's so nice that Fogsi is doing it with Chhattisgarh OBGYN Society, Madhya Pradesh OBGYN Society, and that the Public Awareness Committee of Fogsi, chaired by you, and Priyankur, who is a national coordinator. Whenever Priyankur calls me up, I just see whether I have any commitment or not. Even if there is a commitment, just to promote Northeast, I never say no to him. Never say no. That is what I believe that we should do for Fogsi. So, and it is so nice to have 3 ladies with whom I am sharing this platform. Dr. Jyoti Bindal, Dr. Rosa Olai, and Dr. Archana Based, all 3 from MP. Not only that, as you have already covered most of the things related to fibroid, what I would like to say that people come to me, my close relatives, friends, for second opinion, for hysterectomy. And then it becomes so painful sometimes to say that do not undergo this hysterectomy. You can go for medical line of treatment and all that. So I think to some extent, we are also to be blamed for a lot of uteri being removed without real indications. It is so nice to have a candidate for president's post of Fogsi, a dear friend, Dr. Jaideep Tank, who is going to deliver the first talk on medical management of fibroid uterus, and Dr. Geeta Guin, who is going to talk on medical legal aspects. That is again equally important for hysterectomy. This is the first time I have seen 2 in webinar. There are 2 panel discussions, and I think it is going to be a very long evening for all of us. But I'm sure people will learn a lot. And thank you very much, Priyankur, Kalyan, both of you, and the Fogsi office bearers for inviting me to be here with you all and sharing this platform. Thank you so much, and wish you all the very best, Kalyan and Priyankur. Thank you.
Thank you, sir, for your blessings. It is indeed a pleasure that you have blessed us for this webinar. Thank you so much, sir.
Thank you. My pleasure.
Yeah. Thank you so much, Dr. Pikesha, sir, for being here today and for being there in all the programs that we invite you for, sir. Thank you so much for always gracing, for honoring the occasions, and always for your encouraging words. Thank you so much, sir, for being here. So now it gives me pleasure in welcoming our guest of honors for today's evening. First of all, I would like to welcome Dr. Jyoti Bindal, ma'am, another teacher of teachers, currently the Vice Chancellor of the Sri Aurobindo University in Indore. Ma'am has received a number of awards from various platforms, including the Dr. J.G. Jolly Oration Award by the National Academy of Medical Sciences, the Fogsi Shiromani Award in 2020, and also a number of other awards. She is currently the president of the AMPOX, that is the Association of Madhya Pradesh OBGYN Society, and ma'am is directly related to various government organizations as an advisor or directly participating in various programs. Ma'am, it's a pleasure you have joined us. Requesting you to kindly say a few words to all present here today.
Thank you so much, Priyanka, for such a nice introduction. And I feel very privileged and humbled to share the platform with Reverend Dr. P.K. Shah. We never thought Dr. Shah to be a non-MP person. We were so closely in Gwalior. We always had him for almost every program of ours. And I remember he actually acted as the father figure for many of the Gwalior members. So all my respects to you, Dr. Shah. And of course, my other co-guests of honor, Archana and Rosa, are such dear friends of mine. It's a pleasure to be here. Dr. Kalyan, what a wonderful thought of the topic, the preserve the uterus. What happened in Bid also happened in Chhattisgarh. It had also happened in a part of Madhya Pradesh, and genuinely, somewhere or the other, though Fogsi put up a big fight, but some of the gynecologists were responsible. Honestly, there were a lot of unnecessary hysterectomies going on. And having said that, I would definitely say that preserve the uterus is a very, very welcome step. And as Dr. Shah rightly said, in last 3 years, this crusade of yours has come a long way. A lot of gynecologists are aware of this. And as Chairman Public Awareness Committee, you've done a tremendous job. Dr. Jaideep Tank, we're looking forward to hearing you as always. We are looking forward to your welcoming us we're looking forward to your leading us as Fogsi president in future. It's going to be a pleasure to hear you. And of course, I cannot thank enough the bubbly Priyankur. Once again, thank you so much for having me with you in this wonderful evening program. Thank you.
Thank you so much, ma'am. Thank you for joining us in spite of your busy schedule, and it means a lot to all of us present here. Thank you so much, ma'am. Next, I would like to invite our next guest of honor, none other than Dr. Rosa Olvai, ma'am, an ever-smiling lady and always there for encouraging us in all our endeavors. She has been a past Vice President of Fogsi, Vice President of the Family Planning Association of India, and has also been the Representative Board of Trustees of the HUQUQ of South Asia. She is currently the member of the State Bhilai Council of Madhya Pradesh and also was the chairperson of the Adolescent Health Committee till 2012. Ma'am, it's a pleasure you have joined us. Thank you so much for being here. Requesting you for a few words of blessings to all present here.
Thank you, Priyanka, for the kind words. At the outset, I want to congratulate the chairperson of the Public Awareness Committee, Dr. Kalyan Barmade. Excellent work. I've been actually invited in most of your programs, and I've seen the way the committee has grown under your leadership. And I'm very much sure that your coordinator, Priyanka, is going to do a great job, hopefully, in the committee in the future. Best of luck to you, Priyanka. Well, it's such a pleasure to be sharing the stage with none of the persons like Dr. Professor P.K. Shah here. We have such good memories of you, sir, as a president of Fogsi, and it was during your tenure that you gave me the award of the best committee chairperson at Adolescent Committee. I can never forget that. A renowned teacher, the best of best I know in imaging sciences, ultrasound, and the books that you have written, all of us have been reading it. I'm so glad to be with Dr. Jyoti Bindal in the same stage. Professor Bindal, kind of a laureate, brought up Gwalior and Madhya Pradesh in the national level. Let me tell you that she has been the best student, one of the favorites of my mother-in-law. And I'm sure if she was alive, she would have been proud to see you doing such great work right now. And truly, we are proud to have you in Madhya Pradesh with us. So she treated you like your own daughter. So what a blessing, I wish she was alive here. Of course, Archana Beser is doing great work. She's brought the name of Indore as a vice president, past vice president. Great speakers to begin with. Welcome, Dr. Jaideep Tank. It's lovely to hear from you. Always crisp, to the point, and wish you all the best for your elections this year as a president. Hope to see you coming back to Madhya Pradesh in person in one of the conferences again. Of course, Dr. Geeta Grin, a good friend of mine from Jabalpur, is going to be speaking again, and a subject very close to my heart, AUB in adolescent. Manoj has been working in the committee with me long back, but Sampat Kumari as an expert, excellent chairperson of the committee. I know you're going to give us the best of best. Welcome from Chennai all the way here. Then we have another panel, 2 panels today, excellent, who's going to be by an expert, none other than I think Dr. Suvarna Karnikar here. And you've got your great panelists who are with you. I can see few names here. Manila Jain is here. Jyoti, of course, Banglawala from You're Not Well. You've joined today, you were telling me. Dr. Urmila from Gwalior. I can see Richa, Monica, and whoever is, I can see Sumitra also. Most of you have closed your videos, so I won't be able to mention all your names, but lovely to see all of you. And Priyankar, very good to have involved a number of speakers together. And that's what the teamwork is all about. I was always encouraging people, friends to get together because as a team, we can go forward. So wish you all the best. Enough has been told about preservation of uterus. I won't take your time. So Priya, welcome all the way from Patna. I just saw you just now. I just saw you right now. Wish you all the best for your committee chairpersons elections as well.
Thank you.
So wish you all the best. Thank you. Over to you, Priyanka.
Thank you so much, Rosa ma'am, for joining us, for your blessings and for the encouraging words. Thank you, ma'am. Unfortunately, Archana ma'am couldn't join us yet. Once she joins us, we'll take her blessings through the webinar. So now I would like to move on to the scientific session, and I would like to thank our chief guest, Dr. P.K. Shah sir, the guest of honors, Dr. Jyoti Bindal ma'am, Dr. Rosa Ulvai ma'am, who have already joined us, and Dr. Archana Basir ma'am will join us in the near future. Thank you so much once again. So moving on to the scientific session now. And before I move on to the scientific session, I would like to thank Dr. Manoj Chellani sir, who has helped us a lot in formulating this program and this drafting and designing the faculty. So thank you so much, Manoj sir, for helping us out with this. Thank you so much. So I'm now moving on. I would like to welcome the chairpersons for the first session. I would like to welcome Dr. Meena Nayak ma'am. Ma'am is currently, she is a professor at the Department of OBGYN at Bhilai, SSIMS Bhilai. She's also the secretary of the Bhilai OBGYN Society. Welcome, ma'am. With her to chair this session, we have Dr. Richa Sharma, ma'am, who ma'am is currently the president of the Ujjain OBGYN Society. She's a consultant gynecologist at the Pushpa Mission Hospital in Ujjain. I'm sorry, she's the secretary of the Ujjain Society. Welcome, Richa, ma'am. And we also have with us Dr. Supriya Jaiswal, ma'am, who is currently the secretary of the Patna OBGYN Society. She is the East Zone coordinator of the Adolescent Health Committee of Fogsi. So welcome, Dr. Supriya. Now I would like to invite Dr. Meena Nayak, ma'am, to kindly invite our first speaker, Dr. Jaideep Tank, for his talk on medical management of fibroid uterus. Dr. Meena Nayak, ma'am. Okay, so if Dr. Richa Sharma ma'am is with us, ma'am, kindly unmute yourself, Dr. Richa Sharma ma'am.
Yes. Good evening, everyone. Please share the CV of Jaideep Tank sir. Okay, it's my pleasure to introduce Dr. Jaideep Tank. He is very well-known name. Now, my best wishes, sir, for your elections, sir, is MD, DNB, DGO, FCPS, and MICOG. And he is Secretary General, Federation of Obstetric Gynec Society of India in 2018-20. He is a project lead, Fogsi USAIDS project in 2024. He is the past president, Mumbai Obstetric Gynec Society. He has awarded as FRCOG honors and COSCA in 2020 by Royal College of Obstetric and Gynecologist. He is sir is the past chair publications in the newsletter and committee in AOFG. He is the past chair for reproductive endocrine gynecology and infertility committee of AOFOG. He is past chair MTP committee of Fogsi. He is presently consultant Ashwini Maternity and Surgical Hospital. And sir, now, sir, it's my honor to introduce you. Sir, it's now Stage is all yours. So please start your deliberation.
Thank you. Thank you very much.
I'd just like to mention one thing, that sir has been a constant source of encouragement and has been pushing juniors like me to like a lot of platforms, like towards learning, towards academics, towards organizational skills. And it's always a pleasure to listen to sir. And sir, it's such a pleasure that you have joined us today again. I would also like to mention to all of you that we have 400 plus delegates who have joined us today as of now. And sir, all the best for your presidential election. And I'm sure we'll be seeing you as the president in 2024 of Fogsi.
Thank you, Priyanka. Thank you, Dr. Richa Sharma, for that very kind and very generous introduction. I hope I'm audible and my slide is seen. The first slide is the brochure itself.
Yes.
Thank you, Kalyan. It's the brochure. The first slide is the brochure.
Yes.
So I think Kalyan just signaled that it is seen. Let me first begin by thanking and acknowledging the office bearers of Fogsi, Dr. Shanta Kumari, the president, Dr. Madhuri Patel, secretary, and Basab, who's in charge of this committee, and congratulate and thank Kalyan, who is doing such fantastic work as the chair of one of Fogsi's most important committees. I believe that the work of the Public Awareness Committee cuts across all the committees, because at the end of the day, public awareness is something which is required on almost every topic which affects reproduction and women's health. So Kalyan, congratulations on the wonderful work that you're doing. And I think this initiative which you took on Preserve the Uterus really will be something which will bear fruit both in the short as well as the long term. Thank you also to Priyankur. I believe Priyankur should change his designation to National Coordinator, because everything that is happening in the nation, Priyankur seems to be coordinating. And I cannot imagine what Priyankur's phone bill must be like. He's constantly calling up people, constantly reminding them, always with a smile and such a nice way of reminding people, very prompt. So thank you, Priyankur, for all the wonderful work that you're doing for Fogsi and women's health in general. I must say that it's an honor to have Dr. Pcos as the chief guest for this program. I'm sure sir must be tired of hearing this, but I cannot help but say that Dr. Pcos was my examiner when I appeared for my exam in MBBS. And, one of these days, I'm sure sir is going to say he regrets it. But so far, sir has not said that he has regretted passing me in my MBBS exam. So thank you very much for that, sir. Sir was, of course, one of the exemplary secretary generals and then presidents of so many organizations. The guest of honor, Dr. Jyoti Bindal, such eminent personalities, good friend Rosa, Archana. It's always such a pleasure to listen to all of you. And my chairpersons, Dr. Meena Nayak, Dr. Richa Sharma. Thank you, Dr. Richa, for that very kind introduction. And of course, Supriya, who is doing such wonderful work from Patna, both as secretary and as part of several Fogsi activities. I have now finished my term as Secretary General. However, even now when someone says Secretary General, I tend to at least half get out of my chair. I think the whole idea of being Secretary General was so inbuilt into me because I was an office bearer of Fogsi for over 9 years. But one of the greatest pleasures that I had as an office bearer of Fogsi was seeing committees and societies collaborating together. And it is such a delight that so many societies have come together today, represented by the president and secretaries of all the societies. From Chhattisgarh, there's Bhilai, represented by Dr. Sangeeta Kamra and Dr. Meena Nayak. From Bilaspur, Dr. Sangeeta Raman Jogi and Kavita. From Raipur, Ashaji and Tabassum. And then from Madhya Pradesh, of course, the heart of the country. From Bhopal, there is Dr. Anjali and Mudita. From Ratlam, there is Dr. Manisha and Neha. From Gwalior, Dr. Urmila and Dr. Achla. From Rewa, Dr. Saibala and Dr. Padma. From Hoshangabad, Dr. Meeta and Dr. Richa. From Sagar, Dr. Nidhi and Dr. Priyanka. From Indore, Dr. Manila Kaushal and Dr. Jyoti. We are looking forward to coming to Indore, Jyoti and Manila in April very soon. From Singrauli, Dr. Sangeeta and Dr. Mahesh. From Jabalpur, my co-speaker, Dr. Geeta and Sonal. From Ujjain, Dr. P.K. Roy and Dr. Richa. And from Katni, Dr. Uma and Dr. Namrata. Kalyan, Priyankur and the team, you have really put together quite a powerhouse of a faculty, present company excluded, I must say. And you have wonderful chairpersons, Sumitra Yadav and Ajay, moderators for the panel, Manoj and Dr. Sumati, with the expert, Dr. Sampath Kumari, who's done such exemplary work as the chairperson of the Fogsi committee. And of course, you have some excellent panelists, Ashish, Ekika, Pratima, and the presidents and secretaries. And your second panel is going to be moderated by Monica and Ashaji. And of course, you have our past editor and our current deputy secretary, who's doing such a magnificent job with the IT initiative, Suvarna. And I think from all the panelists, Anshu is, I think, not an office bearer yet, and I must acknowledge her also. So thank you very much again, Public Awareness Committee, for having me. And in the next maybe 12 to 15 minutes, I will aim to take you through the medical management of fibroids. Now, it would seem to be a very basic or even a facile topic to a certain extent. However, the fact remains that information on fibroids is probably one of the most controversial things in the minds of the lay public. And since this is the Public Awareness Committee, I must show you this slide. This is a screenshot of a Google search when you do a search for uterine fibroids. Look at the number of results. That's 55 million results when you do a search for uterine fibroids. Now, it's no wonder that if you are going to have so much information thrown at you, that lay people are confused about the various treatment options they have when it comes to fibroids. It's not only lay persons, I must admit. There are sometimes even allied specialty doctors. And this is something which has always sort of shocked me about how little non-gynecology doctors know about gynecology. Typically when they come to you for infertility, you have to start by explaining to them that that is where ovulation takes place. And this is a classic example, and that is medical management of fibroids, and the knowledge about fibroids in general, I would say, is a classic example of how more and more public awareness is required on two fronts. One, that not all fibroids need surgery, and two, that there are medical options available, if not for the treatment of fibroids, at least for the treatment of symptomatology of fibroids. I'm not really sure whether you can actually say that there is a medical treatment available for fibroids. After all, I don't know of any medication, and I'm sure neither do all of you, that can actually take a fibroid away from the uterus once it appears in the uterine wall. The only definitive treatment for fibroids is in fact surgery. The fact, however, remains, and I'm repeating this, and I will repeat this again, that very few fibroids actually need surgery. What we are technically doing when we are using medicines for managing fibroids is not treating fibroids, but rather managing the symptomatology of those fibroids. It's therefore important to look at the symptomatology of fibroids. And that is when one realizes that the majority of women with leiomyomas either remain asymptomatic or develop symptoms very gradually over a period of time. Acute episodes of pain or bleeding are extraordinarily rarely associated or even because of fibroids. When patients do get symptoms, the nature of their complaints is often attributable to the number, size, or locations of the fibroids. For example, large fibroids cause pressure symptoms, which may include pelvic pain and so on. Of course, submucosal leiomyomas are really the ones which cause abnormal uterine bleeding. So it's, as I said, important to understand the symptomatology of fibroids, because when you talk about the medical management, and I've changed the word here, I've used the word management instead of treatment, because that is actually what you are doing when you are using medicines for fibroid. The big question is, what are we actually managing? So if you look at the symptomatology of the fibroid and you look at the medical options that are available of the fibroid, you will realize quite clearly that when you talk about medical management with fibroids, you're essentially talking about managing either abnormal uterine bleeding because of fibroids, pain because of fibroids, or you're making an attempt to manage the fibroid itself. However, and again, I'm reiterating this, the fact remains that most fibroids actually do not need to be treated or even managed. The large, overwhelmingly large majority of fibroids can simply be left alone. And a classic example for this is when you have infertility and some fibroids in the uterine cavity. Because there is more than enough evidence now to show, I believe, that fibroids, unless they impact either the endometrial cavity or the curvature of the fallopian tube, in fact, do not contribute to infertility. Even when the patient who has fibroids gets pregnant, only 0.2% of gravid patients with a myoma could have some cause for concern, and there really is no place for medical termination of a desired pregnancy, even with large or multiple fibroids. You can see some ultrasound pictures over there. These are pictures of our own patients who had multiple fibroids, in some instances fibroids as large as 5 and 7 centimeters. We told them, continue with the pregnancy, we will take things as they come. And in fact, all of them did quite well. So when you're again coming back to the medical management of fibroids, as I said, you are essentially managing AUB with fibroids, pain with fibroids, and the fibroid itself. So let's go to what is abnormal uterine bleeding along with fibroids. FIGO came out with a very nice classification led by Malcolm Munro and Ian Fraser on abnormal uterine bleeding. And they called it the palm coin classification. And I think that it is a useful classification because it will help you to drive management. If you look at that picture in the top corner over there, you will see that's my palm and a coin in my palm, which I always use that picture to remember the palm coin classification. However, FIGO then also came out with a leiomyoma subclassification system. Now, to be very honest, I'm really not sure how useful this is. For me, the important part of fibroids and symptomatology still remains the size and whether the fibroid is encroaching on the endometrial cavity or not. Mentally, I still decide my management of fibroids on that basis. And therefore, whether all these 2 and 5 and 6 and so on and so forth are really required is something I would say that is probably more research oriented rather than clinic oriented. Even if there is a fibroid and you assume that the fibroid is the cause of the abnormal uterine bleeding, particularly for perimenopausal and even postmenopausal women with postmenopausal bleeding, consider an endometrial biopsy. And remember that it's a good idea to obtain an endometrial sample only in the context of a diagnostic hysteroscopy, which has an added advantage that if that fibroid turns out to be submucous, you can simply do a hysteroscopic myomectomy at the same setting. A chart like this could actually be very useful when you are planning a treatment for abnormal uterine bleeding, because it will allow you to focus attention on the problem where you really need to focus. It's not very common. However, sometimes you have patients who have a massive acute episode of abnormal uterine bleeding. The patient will come to you and say, "Doctor, I was lying down and suddenly the whole bed sheet got soaked with clots, or I was in the bathroom and suddenly the whole bathroom seemed to be flooded completely with blood." And you really need to reassure the patient at this time. My personal preference for managing an attack of acute abnormal uterine bleeding remains norethistron, that is synthetic progesterone, because I think that it has a nice balance of acting quite quickly vis-a-vis having a fairly favorable side effect profile. However, if you are managing abnormal uterine bleeding, whether associated with or without fibroids, then those are the recommendations from NICE, which say that you should probably start with NSAIDs, combined oral contraceptives, and norethistron one after another. Don't really consider using danazol, and not to really use ethamsilate for the treatment of heavy menstrual bleeding. For patients who have abnormal uterine bleeding, particularly in those where there is no encroachment in the uterine cavity, I think now the treatment of choice has to be the levonorgestrel bearing intrauterine system. The key, however, over here is to really tell the patient that after insertion of the LNG-IUS, you need to wait for at least 6 cycles to see the benefit of the treatment. So you can continue, say, with OCs or norethistron for those 6 months. And also, after you have put the LNG-IUS, you are going to have a little breakthrough bleeds or irregular bleeding for almost 4 to 5 months. Endometrial ablation was extremely popular once upon a time. I'm not really sure that it is very popular anymore. I was never very fond of it. And I would have to say that at least in my practice, it has more or less been replaced by the use of an LNG-IUS. So to summarize, if you have a fibroid which is less than 3 centimeters and the patient has got abnormal uterine bleeding, consider an LNG-IUS as the first treatment of choice if the patient has got a heavy menstrual bleeding. Of course, you could consider non-hormonal methods like tranexamic acid and NSAIDs, or even hormonal methods like combined oral contraception and cyclical oral progestogens. If the fibroid is more than 3 centimeters in size, and these are again NICE guidelines, to be perfectly honest, I don't know how they have arrived at this figure of 3 centimeters. It seems to be rather arbitrary. For me, still, what remains more important is whether the fibroid is encroaching in the cavity or not encroaching in the cavity. I think it is high time that we start thinking about not simply following the guidelines that are available in the West. And I had participated as a co-author in this publication with Ian Fraser and Dr. Rohana Hatutwa, where we talked about the management of AUB in low and high resource settings, and said that you need to make a distinction in the management between these two kinds of settings. Particularly in low resource settings, women with AUB often delay seeking medical care because of cultural beliefs that heavy bleeding may be actually healthy. And Kalyan and Priyanka, this is where the Public Awareness Committee should be stepping in to make patients aware of the problems of heavy menstrual bleeding. And the fact is that governments and specialist medical organizations have rarely included attention to AUB and HMB, which perhaps has led to the need for these Preserve the Uterus programs. When you have abnormal uterine bleeding, which is associated with anemia, you are sometimes tempted to use parenteral iron, but I would like to remind you that the rate of rise with oral and parenteral iron is actually more or less the same. What is very important is stopping the bleeding. What we normally do is, if the patient presents with an acute episode of bleeding, we start her on norethistron and we start her on hematinics at the same time, and we don't stop the norethistron till her hemoglobin crosses 11.5. Sometimes she takes norethistron for almost 2 months, but the fact that she is not losing blood ensures that her hemoglobin rises quite fast. The second part of managing fibroids with medicines is, of course, pain. It is, however, quite important to remember that pain and fibroids are usually not associated with each other. The patient may have dysmenorrhea sometimes with an incidental finding of fibroids. However, there is really no direct correlation between the presence of fibroid and dysmenorrhea. However, in the instances where you find fibroids and dysmenorrhea together, you can adopt the same treatment scheme that we talked about for abnormal uterine bleeding. Whenever the patient comes with pain, has a fibroid, and is not having her menstruation, think of degeneration or an associated pathology, because pain not related to period is a really very rare symptom in the absence of degeneration. Managing the fibroid per se has got all these options with GnRH, mifepristone, ulipristal, vitamin D. We know that all of them have their limitations. However, most of them seem to be some things which we use to tide over a kind of crisis in patients with fibroids. Mifepristone actually seems to be a very promising agent for giving some good long-term results. However, the fact is that as with GnRH analog, once you stop the medication, there is a good chance the fibroid will come back to its original size. Ulipristal was something which seemed to be promising. However, reports which suggested liver damage, etc., have really put a dampener on the enthusiasm which surrounded it. Vitamin D now seems to be a promising supplement which you can use for women with fibroids. However, the evidence which surrounds this is not necessarily the most robust. So in conclusion, there are a number of medical therapies now available for the management of certain women. Appropriate selection of medical management will depend largely on the degree of symptomatology and overall goals. And what seem to be promising right now are GnRH agonists, mifepristone, and vitamin D as some which are going to be useful for managing. Kalyan referred to the bead incident, and I'm just showing you a screenshot of the letter that we had written at that time. In fact, it was Kalyan who brought this to our attention. He called me up one day and said, sir, you know, there is this problem in bead where the collector has issued a circular. See, it is important to understand that as an association of professionals, there is no doubt that unnecessary hysterectomy should not be done. But equally, there is no doubt that there should not be unnecessary regulation on hysterectomy. And I think there are two sides of the same coin. Therefore, the reply that we had written and the reply which was accepted by the government at that time actually talked about preserving the uterus. It talked about increasing awareness levels, and it talked about close liaising between Fogsi and the government. So it is not as if we were at loggerheads with the government. However, it was also important to make the government realize that unnecessary regulation, which does not enable us to provide services effectively, is also not really required. Lastly, let me request all of you here to please support me as I stand for the presidency of Fogsi. I have a website. I believe it's the first time that a website has been set up for a Fogsi election. It's called isupportjaidiptang.com. And if you go to the website, you can register your support for me. And I'm so humbled, honored, and delighted to share that literally thousands of Fogsians have already registered their support for me. There is a video blog where a lot of my presentations from a lot of the series that I have convened are available. And there is a Telegram channel that you can join where I keep on uploading whenever I speak in a webinar. Since there are a lot of presidents and secretaries here, I'm going to take this opportunity to specially request them to please nominate me. The process of nomination for the post of presidency is going on. And I think the last date is 14th, but please don't wait till the 14th before you nominate me for the post of President Fogsi. Thank you very much again to the Public Awareness Committee. Thank you, Kalyan, Priyankur, the entire team, and of course, all the presidents and secretaries, the chief guests, guests of honors, and most importantly, the delegates who are all here to listen to us speak on this very important topic. Thank you very much.
Thank you, Jaideep sir. Can I now invite Dr. Supriya Jaiswal ma'am to kindly conclude the talk?
So at the outset, I would like to thank the Public Awareness Committee Chairperson, Dr. Kalyan sir, and Dr. Priyanka Roy, the National Coordinator of this committee, for giving me this opportunity. I thank even the President Fogsi, Dr. Shanta Kumari ma'am, and the Secretary General, Madhuri Patel ma'am. So, sir, thank you and congratulations for the wonderful talk you have given just now. That really, we all fibroids, they don't need treatment, and Public Awareness Committee really needs to make people aware. The way you showed the Google search, what people see on the Google, so we need to be make people aware that just seeing on ultrasound a fibroid, people get panic and they want to get treatment. So not all, once again we have to say, not all fibroids really need treatment, even in case of infertility. The best thing, what I think, you said the fibroid, we have to see whether it is encroaching the cavity of uterus or not. That is really very important. And then LNG IOS, that is also very important. Then although in conclusion, what you said, that although surgical managements remain the only definitive therapy for symptomatic leiomyomas, a number of medical therapies are also now available for the treatment. And GnRH agonists, mifepristone and vitamin D, their role is very important. So sir, your talk was, you have covered everything and made people aware that really we need not panic for having a fibroid. So the number of fibroids, there many a times we have got many number of fibroids, but they are asymptomatic. We need to treat the pain, the AUB, the classification you said. So it was wonderful, sir. You have summed up beautifully and lovely to. And thank for the opportunity to chair your session, sir. I'm very thankful to everyone. Thank you very much.
Thank you, Supriya. Thank you very much.
Thank you, Jaideep sir, for the wonderful talk as always. I've been telling this over and over again, love listening to you and always continue to love listening to your talk, because every talk there's some new message that comes out, and that is a wonderful thing that you have in you to give to the audience every time. So thank you so much.
Thank you, Priyanka.
I would like to thank the chairpersons, Dr. Meena Nayak, Dr. Richa Sharma, and Dr. Supriya Jaiswal for chairing this session. And I would like to also mention over here that it's the faculties who make a program what it is. So I would like to thank our speakers, chairpersons, moderators, expert, and the panelists, and of course our chief guest and guest of honors for being here today, because right now we have 850 plus delegates, which I think in today's day with so many webinars happening is a wonderful number. So thank you so much all of you for being here with us. So now moving on to the second talk, I would like to welcome, first of all, welcome the chairpersons for this session. I would like to welcome Dr. Nidhi Mishra ma'am, who is currently the president of the Sagar OBGYN Society. She's a laparoscopic surgeon and sonologist at the Seva Hospital in Sagar. Welcome, ma'am. With her to chair this session, we have Dr. Sumitra Yadav ma'am, who is one of the most active members in the, everyone in the Indore OBGYN Society is active with AICOG, but we get frequent calls from her for various scientific commitments. So Sumitra Yadav ma'am is the scientific chair of AICOG 2022. She has been also the organizing secretary of IAGE National Conference Star Endogyne in 2019. She has been the vice president of Indore OBGYN Society, and it's a pleasure. Ma'am has joined us today in spite of the busy schedule and AICOG knocking on the doors. Thank you, ma'am, for being here. And our third chairperson for today's session is Dr. Ajay Manesa, who is currently the website coordinator of website committee coordinator of AMOX. He has also worked as the chairperson of the Sexual Medicine Committee Fogsi, and also the member of the NIMC and PCPNDT wing, Government of India. So I would now like to invite Dr. Nidhi Mishra ma'am to kindly invite our next speaker, Dr. Geeta Goin ma'am, for a talk on medical legal aspects in hysterectomy.
Can I share my screen? Please let me share my screen. Yeah.
Can I please invite Dr. Nidhi Mishra ma'am? Let us just introduce you. We'll need the CV slide, right? So after that, you please.
Okay.
Thank you, ma'am. Vashish, please go on. Share.
Yeah, good evening.
Geeta Goin's CV, please. Yes, Nidhi ma'am, please.
Good evening. Yeah. Good evening, everyone. It's a pleasure to introduce Professor Dr. Geeta Guhen, who is our next speaker. She has done MS in OBGYN, LLB, and FICOG. She's a professor at Government and NSCB Medical College, Jabalpur. She's a dedicated teacher and a great learner, critical care obstetrician, endoscopic surgeon, and an accredited menopause practitioner. She is the president of Jabalpur Obstetrics and Gynecological Society for the year 2021 and 22. And she is East Zone Coordinator, Ethics and Medical Legal Committee, Fogsi, past Vice President, Indian Medical Legal Association, Jabalpur. So we have amongst us Dr. Geeta Guhen, who is an expert in this subject, who's going to tell us about medical legal aspects in hysterectomy. I invite Dr. Geeta Guhen for a talk.
Thank you. Thank you so much. Are my slides visible? Is my screen visible?
Not yet, ma'am.
Not yet.
Okay, so now?
Ma'am, we could request you to kindly stop share and share once more, ma'am. It's not visible yet, ma'am.
Okay, wait a minute. I'll do it. Where is? Is it visible now?
No, ma'am. Not yet.
Still not visible because I'm sharing it.
Vashisht, can you please guide ma'am, Vashisht?
Ma'am, at the bottom of the screen, you will find green button.
Yeah, I have
screen.
gone to share screen. I've gone to share screen.
Right. Then you need to select that PPT, ma'am.
Yes, I'm selecting the PPT.
Then you will find share option at right side, bottom of the right side.
Where is my PPT gone now? It was here.
Ma'am, would you like to share it with Vashisht on his mail so that he can share it for you?
Yes, yes.
Okay, I can do that. Vashisht, should I share it with you? What's your mail ID?
Put it in the chat box, Vashisht, please.
Yes, yes, yes.
Thank you.
I'm sorry for the delay.
No problem, ma'am.
Meantime, Dr. Jaideep can continue to talk. Where is my presentation really?
Okay, so in the meantime, can I invite Dr. Sumitra Yadav, ma'am, for a few comments on this talk, please? And also, I'm glad to inform all of you here that we have today delegates from United States. We have 15 delegates from United States. From Canada, we have 4 delegates. And from Netherlands, Oman, South Africa, and Ukraine, we have got 1 delegate each. So the program has been quite widely publicized. And thank you so much for all the delegates who have joined international and national ones. Thank you so much once again. So Mitra ma'am, can I just request you?
Good evening, everybody. It's a great pleasure to be here. And at the outset, let me thank the Public Awareness Committee, Dr. Kalyan and Dr. Priyankur, for giving me an opportunity to be present here. I'm sure Geeta will be able to.
Yeah. Can somebody show me where is the screen share option? It's gone from my screen.
No. You send it to.
I will send my mail ID.
Yeah, just share it with him, and the thing will be okay. Don't worry.
No. I am not panicking, ma'am.
So this is a very important topic. What I realized that hysterectomy is being done rather too frequently, and I feel that Geeta would be touching upon the points that who should be doing it, because this is also very important, and what all would be the prerequisites for doing a hysterectomy? What would be the complications? These are the things that are very important, and how to deal with any complications. That is what we are here to learn. We all know that there could be medical legal complications, but as a gynecologist, we should be able to overcome those complications and to meet with any such thing that would take place.
Just give me a minute because I'm getting, my screen is all humbled up and jumbled up.
Ma'am, kindly stop share.
Meeting, yeah.
Kindly stop share. Then you'll have this email ID which is put in the chat box. So kindly mail it to him. He'll share it for you, ma'am.
Sir, I have already sent my mail ID to ma'am.
Sure.
So as I was telling, medical legal things are very important as of today. All of us are after the consumer forum, and nowadays patients being more aware, they tend to question us for everything. And as Dr. Kalyan had told initially itself, that it is
I'm
very
sorry,
important.
just a minute, I'll interrupt. Priyanka, what's happening is I'm opening my presentation, and the minute I'm going here, the presentation is disappearing. I don't know why.
Ma'am, would request you to kindly share it with him, ma'am. He'll share it for you, ma'am. I think that's better because we'll do this later because delegates are waiting here, ma'am.
I know.
Why don't you please share it with him so that he can do it for you, ma'am, please? Thank you so much.
Ask him to dictate the...
It's in the chat box.
It's in the chat box, yes.
No, I can't see the screen.
I'll tell it to you, ma'am. I'll tell it to you. It's VASHI.
VASHI.
THM. T. Vashisht M. VASHISHTHM at coronaremedies.com.
I'm doing the share screen thing. Share screen. Yeah. After the share screen, it's all going blank. Okay, Priyankur, can you just start with the panel and I'll just try to get this here?
Should we do that, ma'am?
My screen is very funny. I'll show you how it is.
No. Why you have sent the PPT to Vashisht?
Madam, ये hang हो गया लगता है computer.
Okay. We'll go to the panel.
नहीं पा रही हूँ.
Okay, we proceed to the panel.
Yeah.
Sure. Thank you so much. Vashish, please be in touch with Geeta, ma'am. Please get this thing sorted out.
Yes, sir.
Thank you so much. So, so I'm sorry for the inconvenience and we move on to the panel discussion now.
I am sorry, Radha.
No, ma'am, it's okay, ma'am. It happens, so no problem. Thank you so much, ma'am. So I would like to now introduce our moderators for the first panel, that is management of AUB in adolescent and reproductive age group. And I would like to invite the moderators to this session. I would like to invite Dr. Manoj Chelani, sir, who is the past president of the Raipur OBGYN Society. Chairperson Chhattisgarh ISAR is elect for the 2022-24, and he has been the president of the Raipur Menopause Society. Sir has done a lot of work in medical disorders as well, and so I wish him all the best for his future endeavors. Next, I would like to invite Dr. Sumati Premanand, ma'am. She is the executive committee member of the Public Awareness Committee of Fogsi.
Laptop में हो नहीं रहा है, इसलिए बस आ रहा है. पता नहीं क्या problem हो गया.
She is also the executive committee member of Obgy SSI, and ma'am is the medical director at the Darshan Fertility and Women's Medical Center in Chennai. Welcome, ma'am. Our expert for this session, an expert in the adolescent field, I must say, is Dr. Sampath Kumari, ma'am, who is currently the vice president-elect of Fogsi. She has been the chairperson of the Adolescent Health Committee, and I'm truly lucky to say that we also have another prior chairperson of the Adolescent Health Committee, Dr. Rosa Olvai, with us as well in this session. So, ma'am, in case I still see ma'am is there with us, and ma'am, whenever you want to put in your inputs, I'm very sure the moderators would love to take it.
Thank you.
Sampath ma'am is a professor and HOD of the Muthukumaran Medical College and Research Institute in Chennai. She is the founder secretary of the Tamil Nadu Federation of OBGYN and the national correspondent editor of Jogi. Welcome, ma'am. Next, I would like to invite our panelists for this session, Dr. Ashish Khaled, who is the director of the Asha Kiran IVF Center in Pune. He is currently the vice president. He was the vice president of the Pune OBGYN Society and is currently the secretary-elect of the Pune OBGYN Society. So welcome, Dr. Ashish. Ashish has also done a lot of work with family welfare, and Ashish, I will wish you all the best for your future endeavors as well.
Thank you.
So next, I would like to invite Dr. Ekika Singh. Ma'am is the secretary of the Mau OBGYN Society. She is an executive member of the UP ISA State Chapter and a member of the Public Awareness Committee of Fogsi. She is a member of the Young Talent Promotion Committee currently. Welcome, ma'am. Next with us, we have Dr. Uma Nigam, ma'am. She is currently the president of the Katni OBGYN Society, and she is also the president of the Jagrati Society for Social Welfare. Welcome, ma'am. Next with us, we have Dr. Tabassum Dalla, ma'am, who is currently the secretary of the Raipur OBGYN Society. She is the director of the Jubesta Hospital in Raipur. Welcome, ma'am. Next with us, we have Dr. Mudita Jain, who is currently the secretary of the Bhopal OBGYN Society. She is a professor OBGYN at Bhopal and is a member of various societies. Welcome, ma'am. Next with us, we have Dr. Sonal Sahni with us. She is a consultant OBGYN and fertility specialist, and she's practicing in Jabalpur. Ma'am has a number of publications in various national and international journals, and she is also currently the secretary of the Jabalpur OBGYN Society. Welcome, ma'am. Next with us, we have Dr. Priyanka Tiwari. Ma'am is currently the secretary of the Sagar OBGYN Society, and she is an active member of Fogsi and various other organizations. Welcome, ma'am. Next with us, we have Dr. Manila Kaushal, currently the president of the Indore OBGYN Society, and probably one of the societies we'll be visiting recently when the AICOG is going to be held in the month of April. And of course, on behalf of her and the Fogsi, I'd like to invite all of you to join in the AICOG in the month of April. Ma'am has received a number of awards from various platforms and is also associate professor at the MJ Medical College, Indore. And last but not the least, for this panel, we have Dr. Urmila Tripathi with us. She is currently the professor at GR Medical College in Gwalior, currently the president of the Gwalior OBGYN Society, and is an active member of various organizations. It's a pleasure that all of the battery of panelists have joined us. So I hand over this session to the moderators, Dr. Manoj Chellani and Dr. Sumati Premanand, to kindly take us through the next hour on the topic of management of AUB in adolescent and reproductive age group. I would also like to just mention over here that Manoj sir has been down with COVID for the last few days, and in spite of that, it's a great commitment on your part, sir, that you have joined us as a mod and agreed to continue to moderate this panel. So thank you so much, sir, for being here.
Start video.
Thank you, Dr. Priyanka. And it's really a pleasure to me, a very memorable day for me. I feel so at home today. Right from Dr. P.K. Shah, sir, who was Secretary General when I organized the Nozoniva Fogsi in Raipur. Then Dr. Jaideep Tang, sir, whom we have been interacting for such a long time. And most importantly, Rosa Olay, madam, under whom she was my chairperson for Adolescent Committee, and I worked with her and she visited Raipur too. It was a wonderful, wonderful people around me. I feel so good. And Swarna Khadilkar, madam, also. And then all the cities of Madhya Pradesh and Chhattisgarh. I have been grown and brought up in various cities of Madhya Pradesh, be it Jabalpur or Bhopal, Indore, or Gwalior. And last time I visited Jabalpur, where I lived, just in my neighborhood, I just had a physical conference. So thank you so much, everyone, for joining us for this wonderful webinar. Thanks to Dr. Kalyan Barmade and Dr. Priyanka Sinha. Great efforts, great work, and it's really a remarkable tenure. And hope we too get a chance to work like you. You are your inspiration, and hope we are able to work under Dr. Jaideep Tang, sir. Thank you so much. So let's start with our panel. And as all the panelists have been introduced already by Dr. Priyanka. And we have Dr. Jaideep sir has already covered this topic, and we know that in world total women of reproductive age group, the women affected with AUB are around 11%. In India, it's around 18%, and the burden of heavy menstrual bleeding in India, various causes, and 40 to 53% of women aged less than 21 years and those about 21 years complain of excessive bleeding. So routinely we get such type of cases, and the patient comes to our OPD with heavy menstrual bleeding, and around 15% of all gynecological OPD visits and 25% of all gynecological surgeries are done for the same reason. So this does play an important role in our life, and as discussed by the previous thing, there was hysterectomy was very rampant in our part of the world, but thanks to the PSC committee and Dr. Kalyan Barmade, Dr. Jaideep Tang, Dr. Priyanka, and the President Dr. Shanta Kumari, great efforts have been taken, and we are spreading the knowledge to preserve the uterus. So, we know that the impact of AUB on quality of life is great. There's anxiety among the women, there's a decreased quality of life, there's a discomfort, iron deficiency anemia is there. So overall, 60% of women diagnosed with HMB ended up having a hysterectomy within 5 years from the diagnosis. So they get so much, disturbed or frustrated. They just come to a doctor and say, just remove my uterus. I am done with it. I can't just, go on like this. And but it's our duty to counsel her, give her assurance that no, it can, we are there and we have to preserve the uterus. And a palm and colic classification, which has already been discussed, and the A to M mnemonics for the screening is already there. So this is a FIGO classification of palm coin, which I'll discuss. So let's start with the first case. This is 30-year-old girl which comes to OPD, complained of continuous moderate painless bleeding for last 22 days, menarche 22 days back. What clinical history is pertinent? This question I'd like to ask to Dr. Urmila Tripathi, Madam from Kwale. Madam, please.
13-year-old comes to OPD with continuous moderate painless bleeding. Menarche 22 days back. Okay. So we have to investigate her hemoglobin percentage and for her coagulation profile. And detailed menstrual history. Age of menarche they've already given. And whether there is history of any cramping or clots. And then we should go after blood investigations. We must go for her ultrasound also because examination we don't do in a young girl. Okay.
So we will come in next slides how much important is ultrasound and how useful it is in such cases. So as I rightly said, we have to take a proper history. What was the age of menarche, onset of abnormal menses, timing, duration, and quantity of uterine bleeding. What is the interval between the menses and whether she is having cramping and clots. And importantly, weight changes, eating problem, or exercise schedule also. So these days, teenagers, they sometimes do over exercises or they do, things like bulimia or this thing. So it's very important to take their dietary history also. And then we have Dr. Manila Kaushal. What else would you like to ask her or investigate? Malina, ma'am?
Yes, sir. Yeah. So very important is to take a detailed clinical history. That's what you have mentioned. But it is very important to rule out any bleeding disorder because for her, it is the first time that she had bleeding, uterine bleeding. So we need to ask about any gum bleeding, any history of prolonged bleeding following any trauma or operation, then epistaxis. We should always elicit a family history of bleeding disorder. And then we need to even check that whether she has any history of blood transfusion in her past. But more or less in such cases, when a 13-year-old girl comes to your clinic, it is the anxiety on part of the mother and the girl herself. And what they need is just a reassurance and education. So the priority is to assess first that whether she is bleeding that much or not. So one has to have a very clear, detailed history about the menses, the amount, duration, quantity, and whether it really need to be addressed or not, or just a reassurance is what is required.
Yeah, very well rightly said. And so there was no history of easy bruisability, epistaxis, of gum bleeding. There was no significant personal and family history or any drug intake, and she is not sexually active. So on examination, that there was a pallor was mild, no petechiae, weight was around 50 kg, her abdomen soft, no organomegaly, PSPV not done. So what will be your approach towards this little girl, Dr. Uma Nigam, ma'am? Uma, ma'am? Dr. Sonal can take this question. Dr. Sonal Sahani.
Hello. Yes, sir.
Hello. Yeah.
Hello.
Dr. Sonal, can you take this question? Yeah.
Hello. Yes, sir.
Hello. Yeah, ma'am.
Hello.
Audible.
Can you
yes,
hear me?
We can hear you.
Yeah. Sir, and this little girl.
Ma'am, we can hear you.
Yeah. Sir, basic investigation, routine investigation. Her hemoglobin, her blood group, and total blood count and all that. and just symptomatic management. This is the best way, and insurance of the parents. This is because of first time, and menarche is just 2-3 months back. So the major thing is to assurance to the parents, and wait and watch, only symptomatic management, sir. Some investigation like TSH, this is also required, and at the last I'll go for the pelvic sonography.
Okay, ma'am. We'll discuss about the pelvic sonography in subsequent slides. And Dr. Sonal, would you like to add anything? How would you like to go ahead with this and doing evaluation of this patient? Dr. Sonal?
Yes, sir. Sir, so as Dr. Uma has already told, that first of all, foremost history taking and thorough reassurance to the patient. So thorough history taking and then reassurance, because sir, 50% of the cases are due to immature HPO axis, and all that we need is to counsel about diet, nutrition, exercise pattern, and lifestyle to the young patients. So for this patient also, we will similarly go about. And then definitely, sir, to rule out underlying pathology, because we cannot afford to miss the underlying pathological causes. So we can go for a thyroid evaluation.
You're not audible, ma'am.
Am I audible?
Yeah, now you are.
Yeah. Yeah.
Yeah, please carry on.
Yeah, yeah. So, sir, if it is refractory to the basic treatment, then only, sir, we will go for imaging or specialized test for this patient, sir.
Fine. So now we have been talking about the imaging. So is USG needed at initial evaluation? Dr. Ashish?
Good evening, sir. At the outset, I'm thankful to Dr. Kalyan Baramade and PSC team for inviting me. Sir, just to answer your question, majority of the adolescent menorrhagia, when you're talking about 13 years girl, having said that it is a menstrual bleeding which is on a heavier side, all of the panelists they talked about the grading and clinical assessment. I think it's mainly a few years after the menarche, it will be HPO axis which has not been stable. So this could be anovulatory on most of the cases. So routinely, USG is not the answer. And I don't feel that can be advocated as on this particular patient.
Dr. Ekika Singh, ma'am?
Thank you, sir. Thank you very much, sir. Yeah. Thank you. And I really thank Dr. Kalyan Baramade and the PSC committee for inviting me for the panel. And I second Dr. Ashish what he says at the age of 13 year and when she had her menarche 22 day back, ultrasound is not a must, which is the mandatory investigation required. But yes, if we can perform, we can do, then it's not a harm to do a ultrasound for her. But our diagnosis, our treatment protocol should not depend on ultrasound image, what we get at the age of 13 for the patient. That's what I want to say about ultrasonography.
Okay. So Dr. Tabassum, like her HB was 10.5, thyroid profile was normal, population profile normal, USG pelvis shows uterus is normal, ET is 6 mm, both the ovaries are normal. There's no free fluid. So what's your impression and how you will manage this case?
She is an adolescent girl, and if her parameters are all normal, mostly 50% possibility is because of anovulation. Her HPO dysfunction is there. So initially, I would like to reassure her parents, especially her mother, and I would like to offer her her hemoglobin was how much?
10.
It was 10.5.
10. So I would ask her to take proper diet pertaining to a good amount of iron. And I would also advise her some lifestyle modifications at this age itself so that she reduces her weight. She doesn't allow her weight to increase. She is regular in exercising, or she can go for some physical activities like badminton playing or any kind of sports activity she can join. And we should also educate her regarding STDs and also sexually transmitted diseases in future, or maybe at this point of time we should ask her history about her any kind of sexual encounters.
Right.
But can I add something?
Yeah, sure, ma'am. Sure.
So it is. We all know that it would be an immature HPO axis most of the time, but one should take an opportunity to examine such girl. Sometimes, we can see an organomegaly like hepatomegaly, splenomegaly, or even an ovarian tumors in such cases. So a thorough examination is also mandatory in young girl because she has not been seen by anyone before that. So one should not miss all those important reasons.
Right. So, Dr. Priyanka, how would you like to treat this patient?
Sir, as we know, we rule out all systemic disorders like thyroid normal and coagulation profile or anormals. So we treat a symptomatic approach like tranexamic acid, or if they are not working, we go for the hormonal management.
Okay.
Like norethistron or OCPs if needed.
Dr. Mudita, would you like to add on this? How would you like, treat this? How you will start the OCPs and then you will give up? Dr. Mudita, are you there? Dr. Mudita?
Sir, am I audible? Some problem is there with my...
Yeah, you're audible.
Yeah, as Dr. Manila has rightly said that definitely we need to have one clinical examination for such patients. We should not miss that granuloma cell tumors and all, and we can give them analgesics as well as. Firstly, I think, sir, they should be counseled properly. That
you're not audible.
Okay. Urmila ma'am, can you take up this? How you'd like to manage this case? And
yes. Number one is reassurance that the usual example I give to patients in their terms is कि when जब दिया जलता है, तो in the beginning it flickers. It takes time to become a nice flame, and the same thing occurs at the perimenopausal period also. So there can be some irregularities in bleeding. Only if it is heavy, we need to take action. And yes, she has come as a case of heavy bleeding. So one is reassurance. Number two is, of course, like tranexamic acid and these things. And whenever we start hormones, we must tell them we are starting hormones, and it should be a second line. But I have seen cases of such severe bleeding, as you all must also have, that I had to give injection conjugated estrogens 25 milligram 4 to 6 hourly also. And aisa lagta this, the attendants would say ki what, and even blood transfusions are required if it is very heavy bleeding. And the attendants would say ki jitna aap de rahe hain wo to sab bleeding mein chala ja raha hai. So it takes 24 to 48 hours for conjugated equine estrogens to take effect. But since it is number one in India, it is not easily available. This I had seen in Iran. I had used in Iran according to the textbooks and all. So, sir, why not in this? You have mentioned norethistron. Norethistron, the hemostatic dose is 212. This is 5 milligram tablet. So 2 tablets stacked. Then in morning, 1 in the afternoon, and 2 in the evening. So for 2 or 3 days, till the bleeding lessens. And then we lessen the dose of norethistron also. So this is my take.
Yeah.
And then of course in tapering doses.
Yeah. So I will request Sampat Kumari ma'am to kindly give her expert's comment on the management of this case and what she would like to advise her. Sampat Kumari ma'am, please. Yeah, ma'am.
Dr. Manoj, Sampat Kumari here.
Yeah, ma'am. Please go ahead, ma'am.
Hope the first case is over, I think.
Yeah, ma'am.
This is a case and attained menarche only 22 days. As all panelists told, the maturity of HPO axis will be 1 to 2 years. So for this patient, since the hemoglobin is also 10.5, if at all needed, you can go with symptomatic treatment. At this stage, there is no necessity for hormones to be started for a menarche patient up to 13 years old. If the bleeding is very severe and anemia is severe only, we are going for blood transfusions or progesterone. And nowadays, the IV conjugated estrogen is not given in our place. So as far as this patient is concerned, give, if at all needed, give tranexamic acid. 10.5, there is no need for blood transfusion. If the hemoglobin, you can give it emetonic tablets and iron-rich diet. So please wait the patient. It will take 1 year for the maturity of HPO axis. Okay, thank you, Dr. Manoj. Panelist has done a wonderful job. So before starting the hormones, please wait for adolescent. Okay, thank you.
Thank you. Thank you so much, ma'am, for expert comments. Now I hand over the next case to Dr. Sumati, ma'am, please. Dr. Sumati, ma'am, please, this is your case, second case.
Yeah. Thank you, Dr. Manoj Chalani. If though miles apart, we have one thing common among you and me today, which is COVID. And I bring greetings from Chennai to all of you. Thank you, Dr. Kalyan Barmade and Dr. Priyanka Rai for this kind invite and the wonderful online bonanza which is going on, which is with the evergreen topic, which is ever evolving. It feels great to be among you all. So we are proceeding to case number 2. So now we are moving from a person who has just started puberty to a person who has been menstruating for a while. So this is a 15-year-old girl who is coming with her mom with a history of heavy periods every month for about 8 months. She has attained menarche at 12 years of age. So it's 3 years after her menarche now. Her cycles are prolonged, heavy. She's not yet sexually active. There is no significant personal and family history, but her weight is 78 kilos. Her BMI is 30.4. There is no clinical feature of hyperandrogenism. So I would like to ask Dr. Ashish Khaled as to, when you look at this girl, what is the first thing you will address, sir?
Madam, when I'm looking at this particular girl, she's a 15 years of age, and she's having the menstruation after 40 to 42 days. So, and the bleeding is for 7 to 10 days.
There is someone who is having 2 gadgets nearby. So you can just keep it away to be fine. Yeah. Proceed,
so that someone is having, yes,
yeah.
That is the problem. Yeah. So the thing is that whenever she is coming with this prolonged bleeding for 7 to 10 days, it is mandatory to do the clinical examination of the patient, see for the symptoms of the pallor, see for that there is no signs of hyperandrogenism, what you are already talked in the slide. So I think we have to see for the degree of anemia, what type of bleeding she is having. And then we can investigate it for her, because she's having a regular periods. It's not irregular periods. But only the crux in this particular case is having a period for after 40 to 42 days, and that to be for a heavy menstruation. So I personally think that is a complete hemogram that should be done to know what is the severity. Secondly, you should also rule out the components of TSH, which can be deranged in those girls, and definitely ultrasonographic pictures can be helpful.
Okay, thank you, sir. Dr. Ekika Singh, I would like to know, what is the first thing which strikes you when you look at this patient?
Well, ma'am, as it's being shown that her BMI is 30, she is 78 kg weight. So the first thing which strikes is her weight. She is in the obese side. And obviously it is falling along with her history with a prolonged 40 to 42 days cycles. Okay. So in her investigations, whatever Dr. Ashish has said, besides that, I would like to get her prolactin also done. That is, THS prolactin is required.
Can we have the next slide?
Yes.
Sir, can we have the next slide, please? Manoj, sir, can we have the next slide? Yes. Please keep
Yes,
it.
that's what.
Yeah.
Yeah, her prolactin has to be done, and then her LH and FHS, if it is maybe in first go, I might not advise the hormonal profile, but yes, TSH, prolactin, and her history. If she has a family history of obesity in her family, or maybe a history of diabetes in her family, her sibling also is going through the same problem, then maybe her GTT or GCT will be the things, along with an ultrasound, which is at most the first thing which I'll advise for.
Great. Thank you. Dr. Uma Nigam, I would like to know if you would be worried about the volume of the ovaries in this woman, in this girl. The volume of the ovary is 13 and 15 each. Dr. Uma, are you online? If Dr. Uma is not there, Dr. Tabasum, can you take it?
Yes, ma'am.
Yes, please go ahead. Are you worried about the 13 and 15? What does it say to you?
Yes, her ovarian volume is a little higher, it's on higher side. So I'm worried about polycystic ovarian morphology.
Okay.
But I would still not say that she has got a polycystic ovarian syndrome.
Why wouldn't you say, ma'am?
Because she should have other signs of hirsutism also, because all three things should come in line when she is adolescent or 15 years old.
Okay, she has got already three features, ma'am. She has got irregular periods, she is obese, and she has got the volume of ovaries, which is looking as polycystic. Doesn't she already?
But she didn't have any signs of hyperandrogenism like hirsutism or acne. So
Dr.
I would not call
do you
her
agree with this?
Yes.
Dr. Mudita, do you agree that this patient is, and Dr. Sonal, do you all agree that this patient is already polycystic, having polycystic ovarian problem, or is it that?
Yes, ma'am.
Yeah.
She's already having polycystic ovarian syndrome because according to at least two features should be fulfilled according to Rotterdam's criteria.
Exactly.
But in adolescent, you should have three features. All the three features should be present in adolescents.
That's nice. This is a nice discussion going on. Can we have the next slide, please, sir?
Yeah, Dr. Sumati, can I add one thing?
Yes, please.
Yeah,
Please
Dr. Sumati, I just want to say that it is being mentioned everywhere that in adolescents, the ultrasound picture should not be taken into the criteria to diagnose PCOS. So she's just 15-year-old. These young girls do have a polycystic ovarian picture. So I think appearance, they have a polycystic ovary appearance. So probably ultrasound should not be taken into much consideration.
Only criteria. Exactly.
Yes,
this is how when we have a wise panel, this is where this is how we go about fight with each other. So I want Dr. Priyanka Tiwari now to mention about how to go about diagnosing a PCOS. You have a slide here. You can take it for reference, and you could tell us how to go about for a diagnostic algorithm for PCOS. Crisply. Dr. Priyanka, are you here?
Yes, ma'am. Ma'am, first we go for clinical features. Like she has oligomenorrhea or amenorrhea. It may present with amenorrhea or a bleeding disorder. And second, we go for hormone analysis, LH-FSH, and androgens. And the third, we go for USG, and it shows volume of ovaries are large, and pictures are PCOD, polycystic ovarian like.
Okay, fine. And next slide, please.
Madam, can I add something more
please,
to it, if you permit me? Yeah.
Please, sir.
So if really anyone wish to go for the phenotypes, this particularly a girl come onto phenotype B, because there is a PCOM criteria as well as there is no hyperandrogenism. So if you're going for the phenotypes of the PCOM, it is coming under a B group. So in the detailed things.
Exactly. That's right, sir. Okay. Sir, next slide, please. We'll proceed to the next slide. Okay. Now we have an adolescent with an abnormal uterine bleeding. Dr. Manila Kaushal, can you please take this question? How would you treat this person? So all they want is, see, I've been all right for the past 3 years. Now I am gaining weight and I am having prolonged periods, which is disturbing my lifestyle. The mom is bothered, the daughter is bothered. What are the 2 or 3 things you will highlight to start off treatment on this little girl?
So,
Dr. Manila.
Yes, ma'am. So the first thing, I would like to spend more time with both of them because she's a young girl and she needs a lot of education for the same, because we need not to label her with any disease for now because she is an overweight girl, or she is overweight for her age.
Agreed.
So the first thing, she needs to be educated regarding her lifestyle modification, which is not very easy in a teenage girl because they don't take anything positively. So the mother will always keep on saying that she is eating a lot and she's not exercising, and the girl is not taking it very rightly. So a lot of counseling is required. Lifestyle modification has to be given in a very nice order so that she follows it nicely. And as for this girl, she was anemic because of her this bleeding episode. So we need to correct her anemia by giving hematinics and counseling regarding her diet. We could start her on non-hormonal therapy whenever she is having that episodes of bleeding. Give her tranexamic acid, mefenigamic acid as per the doses. And if at all required, then can start on combined oral contraceptive pill, the least dose required.
Okay. Okay. I want Dr. Urmila Tripathi to take this question. It is very easy for us to say lifestyle modification, but it is so difficult to practice that even in our lives. So how exactly are we going to reinforce this diet, exercise, and sleep pattern modification in these youngsters who are most probably sitting and doing online classes for the past 2 years? I'm sure most of us are looking at more and more obese young children who are visiting our clinics, who are so slowly put on weight. It may not be 10 kilos or 15 kilos, but they are definitely 5 kilos more than what they have been in the pre-COVID times. So Dr. Urmila, can you please take this question as to, do you give them any targets? Do you tell them, the percentage of weight loss? What exactly do you tell regarding the lifestyle modification? Because I know that only makes a big difference in this particular patient.
Thank you, ma'am. We must reassure them that you have a lot of mental strength. You can achieve if you want to. And it need not be a very fast and intensive thing. Let it be a slow reduction. Even if it is a 5% weight loss initially, it's okay. And very early, every 15 days, they must not check on their weights. They must give time, 1 month, 2 months, only then. Then we must tell them, you first regularize your timings. Try to follow the biological clock, the diurnal rhythm. So if there is any problem, you fix one time, like getting up time. If you fix whatever time you sleep, if you get up at a fixed time on alarm, then the rest will be taken care of by your body. And long periods of exercise is not required. Intermittent short periods, even 20 minutes morning, 20 minutes evening would do. And as this slide shows, there can be resistance exercises, restorative exercises, and high intensity exercises. Because suddenly if they go for high intensity exercise, sometimes they come with muscle pulls and pains and all, which again, they need to be treated, and her exercise is halted for some time.
Fine. So it is a calorie restricted diet and a consistent exercise aiming at least 10% of weight loss. So unless we give them targets, they are going to come back and say nothing works. So we have to sit with them and then tell why it's not exactly working, because they're not working towards the cause. So I thank the panelists for this wonderful session, and I request Dr. Sampath Kumari, my mentor, and I want her to give an opinion on what else and how we should exactly be treating this particular patient, ma'am. Dr. Sampath.
Yes, Sumati. Wonderful case and wonderful argument by the panelist. As everyone told, PCOS nowadays, 2/3 of all adolescent girls are there because of their obesity. The main treatment, as you told, is lifestyle modification. And as the panelist told, if there is an adolescent girl, they can get nearly 8 bleeding for 8 times. If they have per year, that's enough. So we have to correct the obesity only. If bleeding is irregular, as all of us told, and ovulatory, then you have to start with OC pills. And if they have androgenic features, the OC pills with anti-androgen. If the bleeding is only delayed and no irregularity, no androgenic feature, means only lifestyle modification will be enough. If suppose the family history of diabetes is there and acanthosis is there, then you can add metformin. So there is no necessity for all adolescent girl to start all tablets. Whatever you start, give the tablets. The lifestyle modification, as Sumati told, for an adolescent girl, you cannot tell 30 minutes walk, 30 minutes cycling. So simple exercises you can tell. Ask her to avoid escalator and the lift, and she can walk in the steps. And when she is going to the school, she can get up in the previous bus stop itself and then walk. And if she is going by car, she can walk by 10 minutes in the previous place itself. And she can recollect whatever she has read. So normal, simple exercise if you tell, and you cannot tell them that avoid fast food every time. You can tell you reduce the intake of fast food. Monthly once you take. So as far as adolescent is concerned, PCOS, there is no necessity for ultrasound. Normally we go with the transvaginal. For adolescent, we don't go with the transvaginal, only abdominal. Even if the abdomen scan report it should tell clearly mentioned 10 follicles, 10 millimeter size and volume of 10. So please elicit the history, and depending on the history only we are going to treat the patient. And for all patients, you are going to give lifestyle modification. Counseling. Whole family, please others unmute. Mute. So if you ask only the adolescent girl to stop this, don't take food. The whole family should follow this. When you are taking the fast food and if you are asking the girl not to take, she will not take. So the whole family should cooperate for exercise and diet. Thank you, Sumati.
Thank you, ma'am, for the wonderful practical tips. And Dr. Manoj Chalani, can we please take to the next case?
Sure. Thank you, ma'am, for such a wonderful panel. And next case is now the girl is 25 years old female. She comes with health checkup reports. USG shows endometrial polyp of 1.5 into 1.2 centimeter. Bilateral ovaries are normal. She is planning for pregnancy. Marriage is 3 to 4 years. Past history of family is not significant. Examination is NAD. So what would your advice be? Will you offer hysteroscopic polypectomy or conservative management? And if she wants to defer a pregnancy, what contraception can be offered? And I would like to know the role of LNG-IUS in preventing recurrence of polyp after polypectomy. I think Dr. Ashish Khaled would like to answer this question. Dr. Ashish?
Yes, sir. When you're talking about the polyp, one should be very much known about the 3D ultrasonography, and because she wants to have the pregnancy. When you're doing any sonography, just to have the polyp of this size is not that much important, because the location and the site of the polyp is also important. And any polyp which has been there and couple is trying for the conception and it is not been they are not able to achieve the pregnancy, I think it is better to do a hysteroscopic polypectomy, because all of us know there is called as there are the genes HOXA10 and HOXA11, which is down-regulated in a polyp. So any polyp which is been diagnosed on ultrasonography and which is in the implantation triangle always has to be removed by hysteroscopically. Yes, sir. Thank you.
Very, very rightly said. So this is the treatment tool for AOB for polyp. So when a woman comes with AOB diagnosed with polyp, we do the hysteroscopic polypectomy and send it for histology examination. So if there's a single endometrial polyp, young women desirous of immediate pregnancy, there's no need of further management. But if there are multiple endometrial polyp and woman is not desirous of continued fertility, and if the lesion is benign, then we give her LNG-IUS insertion. And if on histopathology there's a malignancy, then obviously we manage her accordingly. So Dr. Sampat Kumari ma'am, would you like to add on this?
Dr. Sampat?
चलो ठीक है, बाद में करूँगा, फिर अब नहीं आ रहा उसमें,
वो अपडेट ही करना पड़ेगा. Sampat Kumari ma'am, would you like to add on this?
I think it is very comprehensively discussed case, and since the time is running out, can we move on to the next case, sir?
Yeah.
Okay. So this is case number 4. And here we have a 34-year-old woman who has a painless heavy period for the past 1 year. And she has got 2 children, both LSCS, and she has not undergone sterilization. She is anemic, and her thyroid levels are normal, and her ultrasound shows a bulky uterus with an LMU of 8 millimeters with a small ovarian cyst, probably looking like a simple cyst of 2 by 3 centimeters. So I would like to ask Dr. Ekika Singh as to how she will proceed with this patient. Now that you have the investigation reports, she is coming to you for the first time, but she has not taken any treatment. But for the past 1 year, she has been suffering with heavy periods, probably sitting at home, fearing coming to the hospital during the COVID periods. So how exactly would you be treating this ovarian cyst? Would you be concentrating on the bulky uterus? What was the diagnosis in this lady? And what exactly will you be tackling when the patient comes to you? Is it the ultrasound you'll be tackling, or is it the symptom you will be tackling, or both?
Yeah, ma'am. Actually, in her case, the 2 very important things which I can look at it. One is the bleeding is painless, which is for past 1 year. And second thing is on the ultrasound, her endometrium, which is 8 millimeter. I don't know it is at what time, because if she's so heavily bleeding, then the endometrium 8 millimeter.
On the 3rd day of her periods.
So, ma'am, that's a thick endometrium, as it is that time.
Yes.
So, painless heavy bleeding with a thick endometrium goes more in favor of anovulatory bleeding. So, she could be a case of anovulatory bleeding. Jo 34 is not the age, but she could be in the phase of perimenopausal state, where
also gives a history of premenstrual spotting.
And that will definitely come when the endometrium is thick, is on the thicker side. So she has more of an estrogenic effect.
So with the history and this, you are suspecting an endometrial problem.
Yes, that's more of an endometrial problem, and hormonal, it could be anovulatory cycles, which could be the reason for her problem.
Sure. Dr. Uma, can you please let us know as to whether you would go in for an endometrial biopsy straight away in this lady, or would you be treating her with some medication and then follow her up? Dr. Uma Nigam, are you able to hear? Okay, Dr. Tabassum Dalla. Dr. Tabassum?
Yes, madam.
Dr. Tabassum, can you take that question, please? Would you be subjecting her to medication, or looking at this finding and the long duration, would you be asking her to go in for an endometrial biopsy straight away?
If endometrial aspiration is available, I would like to take a endometrial aspiration biopsy for her.
Okay, fine. So that will be, so you wouldn't be, so you would like to evaluate her endometrium to know what the problem is, because this particular person seems to have a year-long
long-term problem.
Year-long problem. Okay, fine. So can I ask Dr. Mudita Jain now as to, now you've done an endometrial biopsy, and you have a person who is in this age group, and I would like you to say, what are the common reports you normally see in your practice? What are the most common reports? You could mention probably 3 common reports which you see in your practice. Dr. Mudita Jain. Otherwise, Dr. Sonal. Dr. Sonal.
Yes, ma'am.
Dr. Sonal, what are the 3 very frequent reports in this sort of patients which you come across in your practice once you've done an endometrial biopsy?
Yeah, ma'am, mostly commonly we get progesterone phase of the cycle, this kind of a report, or benign endometrial hyperplasia. So these are the common reports that we are getting. If we are talking about the common reports, ma'am. And for this patient, madam, one thing is also very sure that she has got endometrial hyperproliferation, the thickness, and she is having a hemoglobin of 9 grams. So that means she has been bleeding really extensively. Her problem is actually genuine, because sometimes patients keep saying that they have menstrual heavy bleeding, but their hemoglobin levels and all that are normal. So definitely this patient has features of
So I'm just highlighting the points as to, practical points, that's all. So Dr. Priyanka Tiwari, if you are planning on an endometrial biopsy on this patient, would you be doing a UA and then a DNC and then going ahead, full anesthesia and biopsy? Or would you do an outpatient endometrial biopsy? Or would you take up this patient for a hysteroscopic biopsy? What would you prefer?
Hysteroscopic biopsy would be better, madam. Because it will give, if instead of repeating the procedure over and over again in the same sitting, we can counsel the patient for a hysteroscopy and attain the sample in the same sitting.
Okay, fine. And Dr. Manila Kaushal, this question is for you. Suppose on this endometrial biopsy, you have found a patient with an endometrium which is showing hyperplasia and atypical changes. She's 34, completed family. What would you be prescribing her? Dr.
Okay, madam, with atypia.
With the atypia, yes.
Yeah,
she's got atypical changes, proliferative endometrium. She's got endometrial hyperplasia with atypical changes.
Yeah. So as per the recommendation, if it is without atypia, we can do it with the LNG IUS so that the proliferation and the regression, histopathological regression happens. But if we see an atypia, then obviously we have to counsel for a definite management and should advise her for hysterectomy.
If she's not willing for hysterectomy, do you have
then LNG IUS would be because for such kind of patient, madam, I would have counseled her directly for this endometrial aspiration and LNG IUS, because that would be, because she has completed her family and definitely she needs some contraception as well. And then, yes, if it is atypia, we have to follow her up every 6 monthly for histopathological evaluation. And if at all she's not compliant or something else is coming up in between, then obviously definitely.
Okay. Because she's a 34-year-old who would not like to.
And the whole thing is about preservation of uterus. So we should not talk about
it is fair enough for a 34-year-old to ask for, I want to keep my uterus back because I want to stay young, and she's not yet ligated. She might even want to have another child. We have no control over it. So and this is the reason why I brought up this question, uterine preservation in atypia and how we need to exactly follow up. The last question is for Dr. Urmila. Can you please sum up this case, ma'am? Dr. Urmila. Dr. Urmila, do you have a place for endometrial ablation in this patient? Endometrial ablation. Can you highlight endometrial ablation? Would you, is endometrial ablation a recommended practice in the current day obstetrics? I mean, gynecology?
No, madam, it is not recommended. And what we must advise is this endometrial atypia is there. So as Dr. Manila said, of course, I'll not go first. Madam, are these not the cases for giving medroxyprogesterone from day 5 to day 25?
I wanted one of you all to bring up that thing. That is why I asked you to sum up.
For 9 months, we must give right in the TDS doses, 10 milligram thrice a day for 20 days from 5th day of the cycle. And then after a gap of 1 or 2 months, we must do a check endometrial curettage to find out the status of the endometrium.
This is a lifelong patient, and if she wants to retain, I think probably she'll be on a long-term follow-up. So thank you very much. And I request Dr. Sampath Kumari to come up with the additional information and the practical points. Dr.
Thank
Sampath?
You,
yes,
yes Sumati. Thank you, Sumati. For the third case, I was seeing one patient, so I was not able to give. 1 minute, Sumati. For that Manoj case, for the endometrial polyp, it is better since she is planning for pregnancy, means hysteroscopically, you have to remove it. Then only the bleeding will also get stopped and she can plan for pregnancy. And for this fourth case, we had a wonderful discussion by all panelists. She is only 34 years old. So you have to preserve the uterus. So first, you should give the option to the patient. What are all the options available? First, you give the medical management, at least for 6 to 9 months. And if it is not working only, as she told, this progesterone can be given. Nowadays, very good choice is LNG IUCD. That is the very good choice. With this LNG IUCD, you can repeat the endometrial biopsy also with the people's forceps. So that, as Sumati told, if it is an atypia, it can get reverted. If it is normal, there is with the progesterone tablet itself, it can go. with the ATP, as far as I am concerned, this patient is for LNG. Since she may be planning for the next pregnancy, as Sumati was telling, if she is planning for other pregnancy, means you cannot go with endometrial ablation. So you have to go with the progesterone or LNG. And if she wants to plan pregnancy, you took the endometrial biopsy and confirm, and then she can, if needed, she can go for pregnancy also. So as far as possible, preserve the uterus. Thank you, Sumati.
Thank you. Thank you so much, ma'am. We have got one more case, but I think we are running short of time. It's almost 1 hour for this panel. And we have got one panel and one talk. So, Priyanka, can we stop it here? Because
wonderful panel, Manoj and Sumati. Thanks a lot. And I thank Priyanka and Baba PAC committee chairperson for the opportunity. Thank you.
Thank you. Thank you. Thank you so much, ma'am. And thanks a lot to my co-moderator, Dr. Sumati. She worked so hard in spite of her ill health. And we tried to communicate with everyone. And thanks to Dr. Umalan Tripathi ma'am from Gwalior, Dr. Manila Kaushal from Indore, Dr. Uma Nigam from Katni, Dr. Sonal Sahani from Jabalpur, Dr. Mudita Jain from Bhopal, Dr. Ashish Khaled from Pune, Dr. Ekika Singh from Mau, Dr. Tabassum Dalla from Raipur, Dr. Priyanka Tiwari from Sagar. So thank you everyone. It was really a wonderful session, and all the best to the contestants for the forthcoming chairperson election, Dr. Ashish Khaled for this committee for this thing, and Dr. Supriya Jaiswal and each and everyone. So all the best to you.
All the best, Manoj, for you.
Thank you. Thank you, Manoj sir.
All the best to all of you, and thank you. It was very nice.
Thank you, madam.
Here. Thank you.
Thank you. Thank you so much. Yeah. Thank you.
Thank you very much. All the best.
Thank you.
Thank you. Thank you so much, ma'am.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you. Thank you from me too.
Hi, Sonal.
Thank
Hi.
you.
Dr. Priyanka, can you take up now? Dr. Priyanka?
I guess Priyanka is resting, so I can move forward.
Yeah, sure,
Yeah,
ma'am.
please.
We are eagerly waiting for your talk, ma'am.
I
Yeah.
already kept you people hanging.
Please carry on,
computer
ma'am.
was not working actually. I'm sorry
Yeah.
for that.
Please go ahead, ma'am.
I have my presentation and my chairpersons are in, I guess. My chairpersons are in, yeah. So I'll start with my presentation without taking much.
Sure. Welcome.
And Priyanka gave me just 10 minutes, so I will finish it off in 10 minutes. My objective is to just sensitize you on the medico-legal in hysterectomy. Next slide. Next slide. Somebody is changing the slide. Yeah. So the medical legal issues in hysterectomy can either arise from the indications for surgery, or it can be procedural, which can be either because of the consent or the complications or the competency of the surgeon. Next slide. I'll go quickly. So coming to the indications, I'm going to briefly take you to certain cases to sensitize you as to how things go on into the courts, because we all understand that as OBGYNs, we face the biggest brunt of the medical legal cases that go on in our consumer forums and even in our courts vis-a-vis the criminal cases. And there is almost a 40% share of gynects in that burden of the medical legal issues that we face. So this, when we are discussing indication, I brought up this case of Amba Hospital versus others and Rampati and others, because one very important judgment lines that the court pronounced in this case is that until the immediate and long-term effects of hysterectomy are not available, we should re-evaluate our philosophy and develop respect to uterus as an important endocrine organ and not merely as a childbearing pouch. This observation of the court comes in the background that this is just a 24-year-old woman who has come to this particular hospital with bleeding PV, and on examination, these people find an adenomatous polyp, which they feel is an adenomatous polyp. They try to control the bleeding, but the bleeding is not controlled. So they take her for a biopsy, but while doing the biopsy, they realize that they cannot go ahead with the biopsy because it is bleeding. They try packing, and eventually proceed with hysterectomy. This adenomatous polyp later turns out to be a malignant polyp. The woman eventually succumbs to the disease, yet the court is humble enough to say that you shouldn't. When the diagnosis is cancer, yet the court is humble enough to say that you shouldn't have done a hysterectomy without a histopathological confirmation, because this particular hospital takes a biopsy, sends it for HPR, but without waiting for the histopathology report, does the hysterectomy. So please understand that every time you do a hysterectomy, you may be very well justified in doing the hysterectomy, but you should be justified in doing the hysterectomy at that particular point of time. Point one. Next slide. Next slide. Whosoever is changing, please go to the next slide. Okay. So when we come to the consent, there will be an overlap of cases. When we come to consent, all of us are very familiar with the Samira Kohli versus the Prabha Manchanda, and another case, a case which was decided in 2008 and actually set up the landmarks of how consent should be vis-a-vis a surgical procedure, in which they stated that consent has to be unique to the procedure. It must clearly mention the indication why the surgery has to be done, who will do the surgery, what is the procedure that will be followed, surgery, what are the alternatives that are available if the patient is not opting for the surgery, how the patient is likely to suffer if she is not going to adopt the surgery and go for the alternate procedures, or if she chooses not to have the procedure at all. Everything has to be procedure specific and explained to the patient. Very important for us to realize is that in Samira Kohli versus Dr. Prabha Manchanda, the courts is opined that doing the hysterectomy was something that was the need of the hour, but it was not to be done as the consent from the patient beforehand was not obtained. So do not proceed with a hysterectomy until it is a life-saving procedure before taking an informed consent from the patient herself. Nobody, not even her husband, stands in the capacity to consent except in a life-saving procedure. I think this Suchita Chaudhary versus the state of Bihar is a very interesting case, because in this case, the ovaries were removed without consent. The patient eventually went to the court and contested that she had given consent for a total abdominal hysterectomy, but her ovaries was removed. But a wise lawyer was good enough to convince the court that total abdominal hysterectomy actually means removing the ovaries as well. And the case was decided in favor of Suchita, Dr. Suchita. So underlining the importance of having a good lawyer to argue for you in the court. This again is a very important case about consent, where Saroj Chandoke underwent the procedure in Sir Gangaram Hospital. She was a previous to section who had consented for an abdominal hysterectomy, but for some reason, the surgeon decided to go for the vaginal route, and in the process, caused injury to her renal vessel, and the patient had to undergo a unilateral nephrectomy. The court took a very adverse view of this particular case, saying that if you have taken consent for an abdominal hysterectomy, stick to it. Why did you do a vaginal procedure? You should have actually explained the pros and cons of the procedure to the patient, and she should have consented to you that, yeah, you may try a vaginal hysterectomy, and therefore the courts were not at all lenient and actually granted compensation to Saroj Chandoke from Sir Gangaram Hospital. To the next slide. To the next slide. I have 10 minutes. Next slide. Yeah. So coming to the complications, I want these cases to go to you as a sort of consolation, because in the first case of Mrs. B. Jyoti versus the Gita Maternity Nursing Home, here the patient is a case of a fibroid of the uterus, and this patient has a ureteric injury, and she was fibroid uterus with previous LSCS, and the Andhra Pradesh State Consumer Redressal Forum was very considerate in taking the various evidences put forth that ureteric injury in a fibroid uterus with previous cesarean section is a known complication, and if this complication did happen, and if the doctors were good enough, please remember, the doctors were good enough in picking up the complication on time, treating the complication as per the guidelines, then no case can be made against these treating doctors just because there was a ureteric injury. So the point to be taken home is that whenever we are doing the procedure, please have in mind the big injuries or big complications that may come up at the time of doing the hysterectomy. For example, if you're operating on a broad ligament fibroid, you have it on your mind that the ureter is close by. If it is a vascular tumor, have it on your mind that we may have vascular injuries or something else is needed. Counsel the patient, take a consent from the patient as to the same. Be honest. If you have had a complication, be honest in communicating with the patient and the relatives, and also treat very diligently and have a team of doctors if you are not confident enough in handling the complication. And the courts will take a very lenient view of the situation, because the courts have clearly mentioned out that just because the procedure has had a complication does not mean that the doctor has been incompetent or is liable to be punished for a negligence. The second case again is of Dr. Nirmala Gupta versus the Combined Medical Institute of Uttarakhand. Here again, there was rectal injury at the time of operating on a patient for hysterectomy where endometriosis was the cause, which was leading to this pain and dyspareunia and bleeding. This patient went to the court and said that the husband and the patient, that these patients reoperated on us, and we were not told that there is a rectal injury, but the lawyer for the doctors went and consisted that when there is a rectal injury, a stoma is made, the stoma was dressed up 3 times in a day. So there is no way the patient can deny having knowledge of the fact that there was an intestinal or rectal injury, and she was treated as the due procedure of the care for rectal injuries required. The injury was closed up after, the rectal injury would be closed up after 3 months, and therefore the courts ruled in favor of the doctors. Again, the take-home message, please do not panic if there is a complication. The point is diagnose and treat as per the accepted medical practice. The next slide. The next slide. Yes. Then this is again, the third point that I say is competence. The first case is about Dr. Reena Bhattacharya versus Dr. Narayan Chaudhary. You know, this is a lady who has come bleeding with postmenopausal bleeding. Dr. Narayan Chaudhary advised an endometrial biopsy and asked his junior to do the endometrial biopsy. The endometrial biopsy did not yield any material, so he decided to go ahead with the procedure of hysterectomy. Unfortunately, at the time of doing the hysterectomy, he made a bladder injury, put the catheter in situ, discharged the patient with the catheter in situ, asking the patient to come back after 14 days without probably not telling the patient, at least not in writing, that the patient had a bladder injury. When the patient had finally come back with dribbling of the urine, then he tried initially to treat the patient, and only it was at a later stage that the patient was referred to a neurosurgeon for treatment. The point taken by the court in this particular case was that the courts took Thielen's book in consideration and said that every gynecologist must know how to diagnose a bladder or bladder injury at least, and must know how to repair the bladder, because that is a process of the total gynecological training. So Dr. Narayan Chaudhary did not manage or did not repair the bladder injury the way he should have. Then he did not communicate. When he did communicate, he tried botching up things at his end, and he was actually late in referring the patient to the neurosurgeon. So the doctor was held responsible for the agony cost of the patient, and the patient was awarded compensation. The take-home message is, when a book like Thielen says, and when we repeatedly keep on teaching that our students must know or must not be scared of bladder injuries, we have to actually encourage our students, and we as gynecologists also have to become familiar with the bladder and learn how to diagnose and treat bladder injuries. The last case which I want to quote here is one case which will set up some landmarks of Ajay Prabhakar Paranjpe versus the state of Maharashtra. As you can see that this was a criminal case which was decided in August 21. What I want to bring home is that Dr. Paranjpe is actually an MS surgery. He did an hysterectomy and landed in a VVF, and the patient went to the court and said that he is a surgeon and he should not have operated. He filed an FIR that he operated without being competent to operate on the patient vis-a-vis the hysterectomy procedure. Dr. Paranjpe produced a lot of OT records of his own hospital and another hospital, and he could actually prove that he had done hundreds of hysterectomies earlier without any complications. So at least the criminal court accepted his argument that vis-a-vis hysterectomy, he was competent enough to do it, and he was not, or he was granted bail. This case would now be contested in the Consumer Forum, and we need to wait and see what the Consumer Forum has to say vis-a-vis the surgeon performing a hysterectomy. Next slide. Next slide, please. So the point to be taken is that hysterectomy is a procedure that all of us need to do at some point of time. There has to be very clear-cut indications for which you are doing. If that there is any reason to suspect that there is abnormal bleeding, and we must keep in mind that whenever the case will go to the court, the textbook will be produced, and every time the textbook is produced, then it will be saying that even in a case of fibroid uterus, like Dr. Jaideep Tang said, please do an endometrial biopsy to rule out an estrogenic malignancy or anything else. So please follow the procedures of the book, because when you go to the court, you will have to prove that you followed the procedures of the court, the procedures quoted in the book. Be vigilant, diagnose the complications, treat them as per the accepted norms, but don't panic. There is nothing wrong if you commit complications. All of us have complications in life. So take due care in the delivery of service from diagnosis, treatment, referral, follow-up, and ancillary care. Thank you so much, and I hope I stuck to my time. Thank you, Priyanka, and thank you everyone for a very patient hearing. I could have spoken for at least an hour and told you stories about hysterectomy, but sorry, Priyanka, for the botch-up, and thank you that you gave me an opportunity to sensitize everyone about the medical legal issues that could come up in hysterectomy. Thank you.
Yeah, Sumitra ma'am, yeah, please go ahead.
Thank you very much, Geeta. The points that you have summarized is all were starting with C, as with COVID. So you have stressed upon the importance of the consent, that many of us are negligent, especially in the private setup. And there is one thing about consent that I would like to add. It is better that instead of the printed consent forms, you should take the consent yourself.
It should be procedure. It should be
procedure based.
Courts have not said that you cannot use the printed form. I wanted to produce a consent for hysterectomy, which has been dismissed by the court. But what the court said is not that you need not use the printed form. The court said that even if you use the printed consent form, be very
You should be
specific
specific
about
about
the
what.
procedure with what you're performing. It should not be a blanket consent like मैंने अपने बेहोशी आवास में डॉक्टर और बेहोशी वाले डॉक्टर को बोल दिया कि आपको जो करना करो और मैं इसकी जिम्मेदारी उठाने तैयार.
Another thing that you stressed upon was complications can occur, but the competency should be something better. That is important because if you don't know to handle that, call for help. So communication is also very important to the patient, that you should inform what complication has occurred. Thank you very much, Geeta, for your nice talk. Thank you, Priyanka, for giving us a chance to be here. Thank you very much.
Thank you.
Thank you, Dr. Geeta Guin, ma'am, for this wonderful talk. Every time I hear a medical legal talk, I get a little scared of my further practice. But then, of course, we know that people like you, the medical legal experts, are there to bail us out of things. And that's when you get the strength back to do whatever we need to do, of course, ethically and with scientific basis following it. Thank you so much, ma'am. So I would now like to also thank the chairpersons, Dr. Niti Mishra, Dr. Sumitra Yadav, and Dr. Ajay Mane for being the chair of this session. Thank you so much, ma'am. So now I would like to go on to the last panel of this program. So this program, the panel is on AUB in perimenopausal and menopausal women. And to moderate this panel, we have Dr. Asha Jain. Ma'am is the director of the SMSA Hospital. She has worked a lot in cancer prevention and relief in Raipur. She is currently the president of the Raipur OBGYN Society and an elected member of the Chhattisgarh Medical Council. Ma'am has worked a lot towards the international academic activities, and wish her all the best for her future endeavors. With her to moderate this panel, we have Dr. Monica Umbardand. She is a very active member of our PSC committee. In fact, most of the programs that happen through PSC are directly coordinated, or she plays an important part in that. So Monica, thank you so much for being there for all PSC. Consultant obstetrician and gynecologist at the Mangalia Nursing Home and Atharva Fertility Center in Solapur. She is the website coordinator of AMOX and also a very important member of the Solapur OBGYN Society. Welcome, Monica.
Thank you, Dr. Priyanka, for such a kind introduction. And in the first instance, I and Asha ma'am would like to thank the Madhya Pradesh and Chhattisgarh Obstetrics and Gynecological Societies and the PSC committee Fogsi for giving us an opportunity to conduct this panel discussion. Can I please share screen now?
I just finished the introductions, Monica. Then we'll go ahead.
You can start.
Thank you. Thank you. So expert for this session, of course, is Dr. Suvarna Khadilkar ma'am. Another expert in the field. She is again a teacher of teachers. She is currently the Joint Secretary General of Fogsi, and ma'am is also the Secretary of the prestigious Mumbai Obstetrics and Gynecological Society. She's a professor and head at the Bombay Hospital Institute of Medical Sciences, Mumbai. And I saw, in spite of a busy schedule, she has joined us right from the beginning, and she was with us right from 6 o'clock onwards. So thank you so much, ma'am, for joining us. And it's a pleasure, and your expert comments, as of course being the past president of the Indian Menopause Society, would be of great benefit to everyone present here. Thank you so much, ma'am. Our panelists for this session, we have Dr. Sangeeta Raman Jogi, ma'am. So I would like to welcome Dr. Sangeeta Raman Jogi, ma'am, who is a professor and head at the Government Medical College in Bilaspur. Ma'am is, she also holds important position in the Bilaspur OBGYN Society, that is the post of the president, and she is a teacher, that is UG and PG examiner, as well as a reviewer for PG thesis for various universities. Welcome, ma'am. Next with us, we have Dr. Kavita Babbar, ma'am. She is a senior consultant laparoscopic surgeon and infertility specialist practicing in Bilaspur. Ma'am is currently the secretary of the Bilaspur OBGYN Society.
Hello.
Number of awards and publications to her credit. Welcome, ma'am. Next, Dr. Maheshwari. Dr. Manisha Maheshwari, ma'am, is currently the president of the Ratlam OBGYN Society. She's an honorary consultant at the Divisional Railway Hospital in Ratlam, and she's practicing for more than 25 years in Ratlam now. Welcome, ma'am. Next with us, we have Dr. Jyoti Manglowala. Ma'am is currently the secretary of the Indore OBGYN Society. She is a very important member of the organizing committee of the AICOG 2022, and she has been an executive committee member of the breast study of breast committee, as well as the International Academic Exchange Committee. Welcome, ma'am. Next with us, we have Dr. Anjali Kanhere, ma'am. Ma'am is a professor and head GMCH in Bhopal. Ma'am is currently the president of the Bhopal Obgy Society. She is a national corresponding editor of Jogi and holds very important positions in many organizations. Welcome, ma'am. Next with us, we have Dr. Neha Saraf. Ma'am is currently the secretary of the Ratlam Obgy Society. She has won a number of awards like the Wonder Foxian Award, the JSG Award for Goods Community Service, and she is a member of various organizations. Welcome, ma'am. Next with us, we have Dr. Richa Paharia, ma'am. She has been into the service for 20 years in public health and presently posted at the Civil Hospital in Itarsi. She has been acknowledged for her exemplary service from various organizations, and she heads the literary and the magazine committee of the IMA Hosangabad. So it's a pleasure to welcome ma'am here. She's also the secretary of the Hosangabad Obgy Society. Next, last but not the least, I would like to welcome Dr. Padma Shukla. So ma'am is she's a senior practitioner practicing in the Sham Shah Medical College as an associate professor in Rewa. She's a member of various organizations, have been awarded a number of awards from various platforms, and she is currently the secretary of the Rewa Obgy Society. Welcome, ma'am. And last but not the least, we have with us Dr. Anshu Baser, a very young, promising and gynecologist from Indore. She is a consultant at the Akash Hospital and Diagnostic Center in Indore. She's a very active member of the Young Talent Promotion Committee, and she has already been awarded a number of awards from various organizations. So welcome, Anshu. So now I hand over this platform to Dr. Asha Jain and Dr. Monica Umbaddan to take us through the next 1 hour on the topic of AUB in perimenopausal and menopausal women, with our expert comments from Dr. Suvarna Khadilkar, and also, of course, expert opinion from the battery of panelists who are there with us today. Thank you so much.
Thank you, Dr. Priyanka. I would welcome Dr. Suvarna Khadilkar, ma'am, and express my gratitude for accepting our invitation to become an expert panel. Can you please allow me to share the screen?
Please go ahead, Monica.
We'll be now moving forward to abnormal uterine bleeding.
Before you start, just to mention over here, because people look a little demotivated, considering the fact that it's already been 2.5 hours, but I would just request and tell you all that we have 1,100 plus delegates who are present with us now. So I'm sure we'll have an excellent panel, and people are looking forward to this wonderful panel. Over to you, Monica. Thank you.
We move ahead with abnormal uterine bleeding in the perimenopausal and menopausal women. Challenges are what makes life interesting, and overcoming them is what makes life meaningful. Generally, when we come across a case, we discuss about what are our experiences with that case, what are the evidences and the guidelines, and the peer observation regarding that case. However, when it comes to the role of a gynecologist, it is systemic evaluation of a patient, the correct diagnosis, a minimalistic attitude, a non-invasive treatment, the counseling of patient, adopting a correct line of management, and then public awareness regarding the same. Ma'am, I now request Dr. Asha Jain, ma'am, to please take over for the first case.
Thank you, Monica, and thank you, Dr. Jaideep Dag sir and Priyanka, Monica, for having me here. So I bring greetings from Raipur. Luckily, everyone who's in the panel is very personally known to me, and I welcome each one of you to this panel, and I hope we'll make it really concise and with a lot of take-home messages. So the first case is of a 46-year-old female who has complaints of heavy and painful periods for the last 2 years. Her cycles are 5 to 6 days, but they are shortened, 18 to 23 days. Her hemoglobin is 9 gram%, vitals are stable. She's 70 kilograms. We don't have her height, so we don't know what is her BMI, but 70 seems to be average sort of. On TVS, her uterus is uniformly enlarged. The size is 10.2 into 7.2 into 6. Myometrium shows a mottled, inhomogeneous texture and had small cystic spaces within the myometrium. The endometrium has a shaggy, indistinct stripe, but it is 9 mm in thickness. The endomyometrial junction is not clear. The right ovary shows a small hemorrhagic cyst of 1.8 into 2 centimeters, and Nothing else significant on her scan. So now these are the basics, and now we proceed. Next, please. This is a pictorial description of how it is, and this is ultrasound report where you can see the area of mottled appearance and the distorted uterine cavity. That means one wall of the uterus is thin and one wall is thick. This is very clear in this report. So now the diagnosis is adenomyosis. Next, please. So what is the diagnosis and what other investigations you would like to do for this patient? Anyone may take the question, please.
Seeing the weight of the patient, though we are not knowing the height of this particular patient, but 70 is the plus size for the weight, 70 kg. So
Yes.
for obesity, I would like to do thyroid function test also for this patient. And there must be a repeat endometrial biopsy. It should be done.
Yes, Jyoti ma'am.
The repeat endometrial biopsy should be done. Thyroid function.
Endometrial biopsy has not been done at all. So yes, we should do an endometrial biopsy. And
there are guidelines to do endometrial biopsy.
We can.
Yes. For every patient above 45 years, we should do endometrial biopsy before proceeding for any.
I think we can probably discuss with the patient and maybe combine it with a treatment. Like if we are, as we said, we are planning to preserve the uterus. So the investigation of choice would be a hysteroscopic endometrial biopsy, and we can, along with that, maybe put an LNG IUS for the patient. So that will be like a one-step treatment for her. Because we are already quite certain with
actually we'll come to that. We'll come to that. Anshu, we'll come to that. But let us first see what investigations you are going to do for her. What further investigations are you going to do?
Madam, if I could intervene, I think a proper history needs to be taken if a patient is hypertensive or not, because at 46, weight 70 kilos, she is at a higher risk of hypertension also. And this could be one of the presentation of of her being hypertensive. And then we can proceed with investigations.
Yes, Anjali. History of taking any oral contraceptive pills or any.
Yes, absolutely. Absolutely.
Why she is unopposed in her body.
Second is her obstetric history also, whether she has had any cesarean section or not.
Okay,
even
so
that is
we are trying to rule out other causes, but now we have a
Good evening,
diagnosis of
ma'am.
adenomyosis. So good evening, Neha.
Hello, ma'am.
Welcome.
Ma'am, just one point, ma'am, because she has a hemorrhagic cyst as well. I would like to go for a MRI pelvis to rule out the spread of endometriosis elsewhere as well. Maybe.
Ma'am, we are talking about adenomyosis
We
and not
have seen the
endometriosis.
size of the cyst is only 1.6 into 2. So that does not look like endometriosis. It is a hemorrhagic cyst. That is a non-ovulatory ovarian follicle. Okay, a follicle that has not ruptured. So that is not endometriosis at all. We are talking about adenomyosis here. So what could be the etiology of adenomyosis?
Scarred uterus and previous DNCs could be the cause.
Okay. What about the pathophysiology? Suvarna madam? Suvarna madam, our expert madam, would you like to say something? Madam, you are muted.
And please unmute.
I think you have nicely written on the slide what is the probable etiopathology, and there is an invagination of the endometrial glands within the myometrium, and there are nest forms which bleed every time the patient has menses, and then the disease goes on increasing month by month as she bleeds. But most of the times the exact cause is not known. It was thought to be common in multiparous women, and more number of deliveries, and endometriosis was considered as a disease of infertile or less parity women. But now we have found that they often coexist, the endometriosis as well as
adenomyosis, they coexist. So I think we really don't, once we diagnose adenomyosis, we know there is no definitive treatment as such to take care of it unless it's a local adenomyoma, which can be resected with our current, laparoscopic way or something. Otherwise, a generalized adenomyosis, the picture which you have shown, I think doesn't, you cannot do surgically unless the final answer is hysterectomy. But we don't want to do hysterectomy here. We want to first try the conservative methods to preserve the uterus. So I'm sure the panelists will come up with certain options as to how you can conserve this uterus. She is having a long period of menorrhagia, I think 2 years. Yes. And that hemorrhagic cyst doesn't bother me, because I think it's just a simple, and the ultrasound is usually very, very specific. They can differentiate between a hemorrhagic cyst and an endometriotic cyst. So I think you should be able to treat with conservative way, but you have to first do her endometrium examination under anesthesia to the endometrium. Somebody, I think, suggested hysteroscopic biopsy to rule out any malignancy. I think Dr. Anjali also mentioned that there should be clear-cut ruling out of high risks of endometrial cancer. Like, is she diabetic? Is she, hypertensive? She's already obese, a little bit on obese side. So we have to rule out endometrial cancer as well, because nowadays we are seeing endometrial cancer in obese women earlier and earlier. It is not only the disease of beyond 50, even earlier you do get endometrial cancer cases. So I think you can do hysteroscopy. You can see if there are any targeted biopsy you can take, rule out endometrial cancer, and try and insert the LNG IUS if the size of the uterus permits insertion.
Thank you, ma'am. Thank you. Next slide, please.
Ma'am. Good evening, madam.
So, yes, Dr. Padma. So
Dr.
the
Padma.
endometrial aspirate shows secretory endometrium. So now you've done the endometrium. Endometrium is normal, secretory. Now, what is your impression and how will you manage this case? Dr. Padma?
Yes, ma'am. One more thing, ma'am, I want to say in history also, that we should ask about any family history of carcinoma, any type of cancer, like even rectal cancer or prostate cancer, or even in family in the father, or in brother, or even we can ask about the history of ovarian and endometrial cancer in mother. Even most of the patient, even they are very educated people, but they come up with all these things. So even we should ask the history about any history of carcinoma in the family. Secondly, ma'am, as you said that if there is secretory endometrium is there, so it means cycles are ovulatory, and what we can go for the progesterone. Either we can give her oral progesterone, or we can, after doing DNC, we can go for LNG IUCD to protect her uterus, to preserve her uterus.
Well, actually, as you must have, as you remember, her cycles are between 18 to 23 days. Dr.
Yes,
Neha,
ma'am.
what would you like to say about it? Cycles are very short.
Yes, ma'am. Cycles are short. She's having menorrhagia. I think I would like to go with tablet dinogestrel 2 mg, or the combination pills dinogestrel plus ethinyl estradiol if she wants to have regular.
Actually, the ideal management is the combined pill only, because the LNG IUS, it will need 6 months, more 6 months to settle the IUS in the uterus, and the patient is suffering since last 2 years. As in your case presentation, you said the patient is suffering from heavy menstrual bleeding since 2 years. So another 6 months will be a big toll on her, and she is 46 years. So ideally start with the combined OC pills only, and tranexamic acid, and we should do her serum ferritin and serum iron, and try to improve her iron level, and because she is having hemoglobin 9 gram only. So
that's really nice, Dr. Jyoti. Now, one question from me. Would you combine LNG IUS with an OC pill?
Yes, we can.
Yes, ma'am. Yes,
We
ma'am.
can.
Am I audible?
Yes.
Yes.
Ideal situation is combine the OC pill with the IUS. So the initial 2-3 months, the OC pills will taken care of the settlement of the IUS.
I also absolutely agree with this.
Yes,
Suvarna madam, would you like to add something?
Yeah, I don't want to add anything here, but a kind of important message I want to give. Yes, we are at a seminar which is titled Preserve the Uterus. Here is a patient who has been bleeding since 2 years. I'm sure she must have gone to several gynecologists. I'm sure she must have taken several courses of hormones and all. I did not see the history, but maybe she has gone to several doctors, but she has not undertaken the endometrial biopsy. So that first thing we do, we rule out. And you have said that there is a secretory, and in spite of the secretory endometrium, if she continues to bleed, how far this progesterones are going to help her? She is producing progesterone. So I think after a reasonable trial with hormones and medical treatment, you should not go to the extreme of conservation of uterus. I want to give that important message. I am personally for conserving. I have conducted more than 100 CMEs when I was the chairperson of endocrine committee, and my title of CMEs was Save the Uterus. Saving the uterus, and I went all over the places and I have conducted that. In fact, this movement started in 2011 when I was the endocrine chairperson. It is not just 2019. And so it is not, I am saying it that don't just insist that no, we don't want to remove uterus. We don't want to. At a stage will come where all other medical and other conservative measures fail, her hemoglobin is dropping. So then you may have to opt for some other treatments or some more radical treatment, or a hysterectomy if she doesn't respond to any other conservative treatment. So that is the message. I think all of you remember that. Don't go to the extreme of no, I won't remove. No, I won't remove. Don't do that. That is my just general message.
Thank you, ma'am. Thank you. Next slide, please.
Yes, ma'am.
So first, remembering what Suvarna madam has said, that, don't be fixated on a conservative treatment, but still the first line is medical treatment. So Neha, would you please like to detail a bit on what medical treatments we have available? And I would also like your input on how effective you find them in cases of adenomyosis. Not generally, but in adenomyosis, how effective are medical treatments?
Ma'am, earlier we used to prescribe plain OC pills. Now we have shifted to the combination OC pills, the combination with Dynogest. And I find the combination pills or using the plain Dynogest 2 mg continuously for 3 to 6 months equally effective. The only advantage with combined pills is that the patient has regular menstruation. So like it's a good feeling. The patient is satisfied. And this is the best option which I heard today, combination pills plus LNG IUS. So that by the time LNG IUS settles and it works, the combination pills has done their part.
So thank you. Anjali madam? Anjali madam?
Yes, ma'am.
Yes, ma'am. Your personal take on this?
I entirely agree. Proper counseling, and once we have a hysteroscopy and a biopsy report, it is easy to counsel the patient. Then we can go ahead with OCPs or the newer combinations of Dynogest with ethynyl estradiol. And if it doesn't work, then definitely IUI levonorgestrel device insertion. And as Suvarna madam has rightly said, still if the patient is suffering, because madam, you will also agree, sitting at Bhopal, I get patients from remote places also. Those patients can't keep on coming back again and again. So if you give them a time period, 4 months or 6 months, they know that, okay, after 4 months or 6 months, if they don't improve, a definitive treatment will be offered to them. And as madam has rightly said, we should not stretch too far, and a proper treatment modality should be offered to the patient.
Thank you. Dr. Sangeeta Jogi ma'am? You're there? Sangeeta is there? Kavita?
Can I say
No.
one more thing? How many of you have tried ormeloxifene?
Madam,
Not for
honestly,
adenomyosis, ma'am.
I don't like it.
No, I like the drug, but not for adenomyosis.
Adenomyosis.
Not for adenomyosis.
Yeah.
Yes, ma'am, not for adenomyosis.
Okay.
So next slide, please.
Yes, ma'am.
So this we've already discussed, that it reduces menstrual bleeding, pain, and uterine volume, and has an overall satisfaction of 72%. So now these 72% are taken care of by the LNGIUS. Now we are proceeding to the remaining 28%. Next slide, please. Next, please. The remaining 28 who are not happy with an LNGIUS, what minimally invasive techniques are you going to use? Dr. Anshu? You're muted. You're muted.
Yeah. Like Dr. Varna Madam said, if we have a local adenomyosis, you can do adenomyoma excision, or laparoscopically is the rule nowadays. Now again, focal necrosis, maybe we do not routinely do endometrial ablation for adenomyosis. Maybe if it is a small focus, then we can do a combination resection along with the hormonal treatment. But I don't think I don't think minimally invasive surgery in this case would be really have a very good role in this particular case.
Agree. She's 46 years old and already, I think, sick of her symptoms.
Symptoms, yeah.
Yeah. So next slide, please. Dr. Richa, would you like to say something about conservative surgical treatment? Debulking or cytoreductive surgeries?
Hello,
Laparotomy techniques?
madam? Am I audible, madam?
Yes,
Yes, ma'am, you're audible now.
Yeah. I'm so sorry. Actually, I was in the mid of an emergency. A patient convulsed post-seizure, so I was attending to her. Yeah. The debulking and cytoreductive surgeries, just as she mentioned, in this case, a very young patient, I don't think adenomyosis.
No, she's not young. She's 46. She's 46.
All right. Sorry.
46 is
she's
young,
46.
madam, I think.
Yeah. Comparatively young. Yeah. I'm almost there, so I would call her young. So yes, we can go in for wedge resections in these cases if because she has already completed with her family. So we will not be much worried about if the uterine wall has a scar or something like that. We can go in for several laparotomy techniques, just as you've mentioned, like the wedge resections and transverse edge-shaped dissections, double flaps, and asymmetrical dissection methods. As far as laparoscopy is concerned, this is a very focal pathology. So we'll have to see how good it goes with it depends on because adenomyosis and laparoscopy, these patients don't really fare very well because a part of it is still left out. And if we go in there, then we may even add to the adenomyosis, some part of the endometrium goes in. So I think in this case, the best treatment would be hysterectomy, though that will be something against the topic that we are talking about. That is what I think so.
Thank you, Dr. Richa. Next slide. So this we've already discussed. Next slide, please. Anybody has an experience of high intensity focused ultrasound or HIFU?
No,
Have
ma'am.
any of you used it?
No, madam.
No, madam.
So Varna, madam?
We are I don't think I have any experience, but see, generally there is a highly selective cases which can go for this. So not all cases can go for this, and means people are not really very happy with the even the outcomes of HIFU. But those who are experienced can tell better. I don't have any experience on this.
Okay. Okay. Thank you, ma'am. Next slide, please. What about uterine artery embolization in such cases? One thing before we discuss this, I would like to ask, how many of your patients, what percentage are really determined to keep their uterus in cases of adenomyosis? Means I would like a one-liner from each one of the panelists, that if she's 46, she's suffering for 2 years, how many want to go through all these fancy treatments? What percentage of your patients?
I would say around 10%, 20%. By the time they come to you, they've already made up their mind to get a hysterectomy done. And if you say otherwise, then they will go to somebody else. Is what the
No, what I'm saying is, what percentage want to keep the uterus?
Around
50%.
20%, 20-25% maximum.
With such history, ma'am, with such history, 0%.
0%, yes.
With such history, she's already pissed off since last 2 years. I don't think she'll be wanting any more of her cycles.
Yeah, she'll be like,
Yeah, I think, madam, around 20 to 30% of patients in the scenario where I work, they want to keep their uterus. But
madam?
The same 20 to 30%.
They would still want to keep the uterus?
Yes, madam. If you counsel them well, and if you give them a time period for review, they do agree with it.
Okay. Dr. Padma?
Yes, ma'am. 20% patients, they want to preserve the uterus, but 80% of the patients who are having this severe dysmenorrhea, they don't want to preserve their uterus. Even if you counsel them enough, they are not going to want to preserve their uterus.
So now, uterine artery embolization, is it available in your places?
No, madam, not in my.
No, ma'am, not in
Any of the panelists, in any of your places?
Yes,
Madam, at
in Indore.
Bhopal,
In
we do
Indore.
have it.
In Indore, few years ago, some senior was doing, but there is much failure in this particular.
Yeah, we do have it in. We send them to a center in Indore with who's associated with us, but not at our place specifically.
No, but in Indore it is available.
Yes.
It is available. Yes.
It is available.
So,
Madam, even in Bhopal, it is available.
If your patients are getting it done, what are the results?
See, we found it to work well in cases of AV malformations that happen sometimes post-surgery, and even in fibroids, but most of these patients opt for a myomectomy. In adenomyosis, we've not really offered it to patients, so I really cannot comment on the results. But yeah, we have had good results in cases of patients with AV malformations.
Okay. So basically now this is one more thing that is in our armamentarium, that if it is available to you, you can get your patients to try uterine artery embolization and see what the results are. So if we compile all our cases, we would have a reasonable figure, because adenomyosis after a good quality transvaginal ultrasound has become really common. So next slide, please. So next slide. These are the guidelines for hysterectomy. If it's a polyp, then you do a removal. If it's adenomyosis, then you do LNG-IUS, GnRH, add-back therapy, OCP, NSAIDs, progestrogens. Hysterectomy is the last resort. So that's the Fogsi GCPR. Next slide, please. So this is the flow chart in women with abnormal uterine bleeding due to adenomyosis. If they want fertility, obviously that is out in this case, who's already 46 years old. So LNG-IUS. If she doesn't want LNG-IUS, then you're going to do gonadotropin releasing hormone, agonist with add-back therapy. And then combined OCP, danazol, NSAIDs, progestrogens. These are grade level 4, grade B evidences. And not desirous, then the IUCD. And next thing is a hysterectomy. So adenomyectomy, conservative surgery offered in select cases with infertility or with strong desire to retain uterus. So this is something, a very rare procedure at this 46 years of age. Next slide, please. What is add-back therapy? Next slide. What is add-back therapy?
When we give GnRH agonist, along with that, we give OCPs, combined oral contraceptives, to prevent the hormonal estrogenous side effect.
Anti-estrogenic side effect.
Yeah.
Anti-estrogenic side effects.
Yeah.
So you can give low dose estrogen, low dose progesterone, or you can give a tibolone. Okay.
Yeah.
So next slide, please. Suvarna, madam, would you like to say something at the end of this case regarding adenomyosis before we proceed to the second case?
Yeah, actually, I wanted to just say one line that you have picked up a case where most patients go for hysterectomy. I mean, a case of diffuse adenomyosis where most of
she
the
has
centers...
focal adenomyosis. She had focal adenomyosis.
I saw the diffuse areas of this
Only
thing.
on one wall, madam. The other wall was absolutely normal.
Okay, if it is local, yes, still most centers would go ahead with a local surgical resection, but otherwise for diffuse and large uteri of adenomyosis, most centers don't have the advanced, the methods for conserving the uterus. But wherever it is available, if you have faith in that center, please refer your patient there and get as far as possible conserve the uterus. But if it is not possible, patient not willing, patient not affording, because they are all costly treatments, you can go ahead with a hysterectomy. This is the first case of adenomyosis where many patients go for hysterectomy. So I will not be surprised that, so some of them do go for hysterectomy, but otherwise all this is fine. Even GnRH analogs, it's not a 46-year-old, how long she can take? How long she will go ahead with GnRH? There is a limitation of every conservative therapy. So if you can't afford and she's not willing to, be patient with all these conservative treatments, then many of them I have seen they land up in hysterectomy. But if they go in hysterectomy, at least be sure in a premenopausal and even postmenopausal patients, if she doesn't have frank endometriosis, please conserve the ovaries. At least we can conserve the ovaries for her health benefits. So it's an important message that if at all she has to go for hysterectomy, try to conserve the ovaries.
Thank you, Dr. Suvarna. Thank you. And over to Monica for the next case.
Thank you, Suvarna ma'am. Your points are very well taken and with very good take-home messages. We now move on to the second case of this evening. She's a 58-year-old female with complaints of first episode of spotting her vagina 3 days back. She's a menopausal lady with menopause at the age of 50 years. Her earlier cycles were regular. She's parent living to with the last delivery 26 years back. She has no history of hypertension, diabetes, tuberculosis, urinary tract infection, or hypothyroidism. No significant family history of malignancy also. On examination, she has mild pallor. Her blood pressure is 146/86. Her weight is 65 kgs. Her per speculum and per vagina examinations have no abnormality that is detected. Breast examination was normal, and there is no evidence of vaginitis. I would like Dr. Manisha ma'am to please tell us about what would be her first line of investigation for this patient. Is Manisha ma'am there? If she's not there, then Dr. Anjali, can you please take up the question, ma'am?
Yes, she's a postmenopausal patient, so definitely a transvaginal sonography is the first thing which I would like to do. Looking at the uterus, the endometrial thickness, and the status of ovary. Then I can proceed with a pap smear. After that, if both these things are okay, then next will be hysteroscopic biopsy.
Any other opinion by any other panelists, Dr. Neha? Dr.
Transvaginal ultrasound is a must to check for thickness of endometrium, because in postmenopausal bleeding, the first thing that comes to my mind is endometrial CA. So we do need to do a biopsy.
Dr. Richa, ma'am?
Yeah, as madam has already.
Ma'am, your voice is not
mentioned,
very clear.
Hysteroscopic guided biopsy would be the best. Just a second. Am I audible now?
Yes, ma'am.
Yeah. I think a hysteroscopic guided biopsy would be the best option in this patient, as her age, she is 58 years old, and PS and PV does not show anything wrong. So a pap smear, I don't think would be that helpful, but a hysteroscopic guided biopsy would be helpful in this case.
Thank you, ma'am. The transvaginal ultrasound of this lady was normal. Her endometrial thickness was 5 millimeter. Both her ovaries were normal. There were no cysts, no free fluid, and no tenderness. The endometrial biopsy showed atrophic endometrium. Hysteroscopy was normal, and no focal lesion was seen, as the rest of the investigations that you would ask for. Now, what would be your line of management, Dr. Ansh?
So I think since we have basically ruled out, like everybody said, we've sequentially ruled out all the causes that we routinely suspect for postmenopausal bleeding. We've seen the endometrium, we've seen the cervix, we've seen the ovaries, and we are fairly certain that there is no evidence of malignancy, and there is only a mild, it is a first episode of spotting and a mild episode. We can probably just try with a hemostatic agent like maybe tranexamic acid, and we've done a sequential management. We've ruled out all the causes, so maybe just a local hemostatic for a few days and her problem should solve.
Dr. Richa, your opinion?
Yeah, I think I would give her an antibiotic course as well. Along with a hemostatic agent like a tranexamic acid, I think I would give her an antibiotic course. And because this can be a case of endometritis, and as such, her endometrium is atrophic, so with little infection, it might bleed. So an antibiotic course with an antifibrinolytic agent, I think that would be my first line of treatment.
Dr. Padma?
Yes, as everything was excluded and the endometrium is atrophic, so I would like to give her tranexamic acid, as well as I would go for sometimes her BP was also high, as you said. So sometimes patient with atrophic endometrium with hypertension, they used to bleed. So I would like to keep the patient on conservative treatment, and I would follow the patient, and I would go for repeat ultrasound TBS after 3 months to see the if patient is asymptomatic. So I would go for the repeat TBS after 3 months, or if she is symptomatic, then I would go for tranexamic acid, as everything is ruled out and there is no and definitely I would like to see the pap smear results also.
Yes.
What the pap smear result, because there is no here is pap smear result is not mentioned. And
yes,
I would like to take ECC also, endometrial curating also.
Yes, so I think most of the panelists have addressed this, but my views and literature are little different in the sense the first episode of postmenopausal spotting, which I think you have written that 3 days back she had episode of spotting and now she's not bleeding. Our issue is not of controlling the bleeding. So giving tranexamic acid today is not really going to help. Besides, I will not go ahead with the hysteroscopy immediately because transvaginal ultrasound is giving you enough information and it is very, very specific nowadays. So here the ET is 5 millimeters. So our cutoff in postmenopausal usually is 4 millimeter. So we have to keep this patient under observation. But here, because you have already done endometrial biopsy and it is showing atrophic, most of the cases it is the atrophic endometrium which sometimes gives little superficial blood vessels. How vaginitis also gives bleeding, the same way atrophic endometritis can give the little bit of bleeding and which spontaneously resolves. So first episode usually we don't go for any invasive management, we can wait, watch, if provided the patient is likely to follow up with you. And you can go ahead with the TVS and see what it is. And if it is, just observe her, give her antibiotics, somebody suggested, give her symptomatic treatments for some time, observe her and see. Most of the times they don't come back with a second episode. But if it is a second episode, yes, all this must be done. And we can do pap smear. You can also do endometrial aspiration, or the people, as you see, you can just quickly aspirate the endometrial contents, which is highly specific for diagnosing of endometrial CA. So if all that is negative, you don't have to worry. So that is what my view would be.
Ma'am, one more thing I want to add, because most of the patients we get in medical college, they are from the villages.
Yes.
And what happens, each patient didn't turn up for follow-up.
Very true, because it is in the setting which you are working. If the
Yes,
patient
ma'am.
is not likely to follow up, you have to go ahead with the next steps. Yes.
Yes,
You're
thank you,
right.
ma'am.
As rightly said, reassurance would be the first step
First
here
step.
for telling the patient that this bleeding is not due to malignancy according to whatever investigations that we have performed. Can any panelist throw a light on using estrogen creams or local estrogen pessaries if required? Is there any role for the same?
Yes.
In this,
Will
Ma'am,
that
I
help?
wanted to suggest that if such patient comes,
this is showing that she does not have
tinnitus.
The PSPV findings in the case were given as normal, but yeah,
Normal. It was only senile vaginitis or dryness which could have caused the bleeding.
So we find estrogen creams in such cases to be quite effective, and the most even sometimes you can add a lubricant as well. So in those are usually quite helpful in cases of senile vaginitis. In this case, it was mentioned as normal, so I did not mention. But yeah, we do prescribe these to patients.
Using estrogen creams and pessaries would definitely warrant first counseling of the patient and a regular follow-up of this patient first. Now going ahead with the flowchart.
Just can I add one more
Yes,
thing?
ma'am, sure.
She is on antihypertensives.
Ma'am, her BP was recorded as 145/85, but she's a non-hypertensive.
Some of them also are on aspirin. So if they are started recently on aspirin or something, then also this kind of spotting takes place. So all this, first of course observe them. We have to think of the worst. Be prepared for the worst. I think of the best condition in your patient.
Definitely.
Yeah, Madam is very right. We in fact had a case who was
Madam
given,
Anna?
I think, rivaroxaban for COVID, and then she ended up with heavy menstrual bleeding. So that is happening, especially.
That is very common nowadays. Yes.
Can we just go through the flowchart right now? If there is a spontaneous postmenopausal bleeding with or without HRT the patient is taking, if she is hemodynamically stable, then we go ahead with an office endometrial biopsy, and the cavity needs to be assessed by hysteroscopy. If there is an adequate histological specimen, then according to the specimen, whatever histopathological review you get, and if the bleeding resolves, we might give the treatment according to the same. If she is not stable, then appropriate resuscitation, making her hemodynamically stable, and then a transvaginal ultrasound and a biopsy. If the endometrium is less than 4 millimeters, then hysteroscopy, endometrial sampling, and removing the target lesion. There is any fluid-filled cavity suggesting of hematometra or pyometra. If not, then expectant management would be advised. The same would represent for a transvaginal ultrasound. Ma'am, if you would like to sum up this case, ma'am. Swarna, ma'am. Let's go ahead. If she's the same way, if she's hemodynamically stable, we do a transvaginal ultrasound for the thickness. If it is less than 4 millimeters and the bleeding resolves, then we can counsel the patient accordingly. If she is more than 4 millimeters, then we do a biopsy. The cavity needs to be assessed and the histopathological specimen needs to be sent, and management according to whatever review we get. If she is not stable, then accordingly we have to first appropriate resuscitation measures, making her stable, and then we can go ahead and do the other investigations like hysteroscopy or endometrial sampling. If any other panelists would like to add something for this case. Swarna ma'am?
No, I think most of the things are
Yes.
very nicely covered. Please go.
Can we move ahead
Yes,
to the third case?
Yes.
This case number 3 is Mrs. V. She is a 39-year-old lady, para 2 living 2, 1 abortion with previous 2 cesarean sections. She presents with complaints of menorrhagia and dysmenorrhea. Her last menstrual cycle was 34 days before, and she has underwent a previous surgery for incisional hernia. On examination, she was pale and her uterus was 14 to 16 weeks gestational size. With the clinical history that we have given, can somebody please throw light on the differential diagnosis?
I think the first would be a leiomyoma.
Yeah.
And then 14 to 16 weeks. Hello.
Ma'am, your voice is not very clear.
Yeah, am I audible now?
Ma'am, it is very feeble. Can you please come in the range?
I'll try with the headphones on.
Yes, ma'am.
Hello. Is it audible now?
Yes, ma'am.
So, madam, I was saying the first thing, this can be a case of leiomyoma, 14 to 16 weeks uterus. And the second, in the differential diagnosis, we can even keep a hydatidiform mole. Though she had a previous period 34 days back, and she does not seem to have any history of brownish discharge or anything, but that can be kept. Gestational trophoblastic disease can be one of the DD. And I think these two are the things that are coming most to my mind.
Dr. Neha? Dr. Anshu?
1 second. Yeah. I think the most obvious one, the first thing that all of us thought after seeing this is most likely a fibroid. It doesn't seem to be a pregnancy related cause. It mostly looks like a gynec cause. So it could be a fibroid. Such 14 to 16 weeks uteruses are uncommon in adenomyosis, but it is still possible. Also, I know that this is a clinical examination, but maybe we need to just rule out if the large size that we're palpating is actually uterine. It could be an ovarian cause also. Sometimes it's hard to differentiate abdominally. So we need to keep that in mind also.
I think Dr. Anshu has rightly pointed out needs to rule out ovarian because she has had surgery for incisional hernia, which will make it difficult for evaluation at times.
The differential diagnosis according to the history would be any unambulatory bleeding, endometrial hyperplasia, leiomyomas, adenomyosis, and endometrial malignancy. Dr. Asha, can you please take the case forward now? Asha, ma'am?
Yeah, yes. Thank you. Can you hear me?
Yes, ma'am.
So the differential diagnosis would be a pregnancy, anovulatory bleeding, endometrial hyperplasia, leiomyoma, adenomyosis, and endometrial carcinoma. Considering she is just 39 years, we could have a couple of these conditions coexisting. Leiomyoma, adenomyosis, endometrial hyperplasia, all because of anovulation could all coexist. So next slide, please. What are the investigations that you're going to do for this patient?
We have to go for...
Yes, who's answering? Dr. Richa?
Madam, Dr. Padma Shukla.
Okay, Padmaji, please proceed.
We have to go for complete blood count and thyroid liver profile. And ma'am, we can go for targeted screening for bleeding disorder as well. For PT, APTT, we can go for that also. If there are any history, we can put out by history also if she is having any kind of bleeding or nasal bleeding, just to rule out any bleeding disorder in the patients. And then followed by, we can go for the transvaginal, abdominal as well as transvaginal sonography.
Yes.
To rule out any lesion, that is fibroid, or whether it is a ovarian cause or it is adenomyosis. And later on we can go for hysteroscopy followed by endometrial biopsy to rule out any endometrial hyperplasia or endometrial carcinoma. And lastly, we can go for MRI as well.
Here there is sonohysterography. So what added information would you get from a sonohysterography? Anjali madam, would you like to say something? The role of sonohysterography in such a case.
I don't have any personal experience and I have not been doing sonohysterography. So I think I would pass it on to someone else who has done it.
Suvarna madam, would you like to say something?
No, even we don't practice sonohysterography so often. But here in this case, could you think of even the scar endometriosis? She's got previous 2 LSCs. The uterus is quite elevated up to the level of 16 weeks. So the ultrasound, what is the size of the uterus? It is the just bulky uterus which is elevated to that level of 16 weeks, or it is just a bigger enlarged uterus, and whether it is showing any fibroids or any, when the scar endometriosis, she will have severe dysmenorrhea. Then nowadays it is so common with previous 2 LSCs, and she also has that another surgery done. So we don't do sonohysterography at all.
Okay. I would like to add that, sonohysterography is good for mapping of a fibroid. It helps if there is invasion into the cavity, what degree of invasion is there is very easy to say if you do a sonohysterography, and then you would not have to do an MRI. So it's either or, that is how it works. And the first test is a pregnancy test. That is, of course, that is the first thing that needs to be done. So
when was her last abortion? Actually, that was not specified.
Around 3 years back, ma'am.
3 years back.
Yes.
Okay.
And her last LMT was 34 days back.
Okay.
Next slide, please. So her pregnancy test is negative. Ultrasound revealed fibroid uterus, hemoglobin 8.6. And she started on iron replacement therapy. Next slide. When you offer her treatment, what are you going to consider? What are the points that you are going to consider when you offer her treatment? Dr. Richa?
Yes, madam, considering she is a young patient and she has a fibroid, so I think the best would be to explain to the patient how it is going to be, and we can put her on medical management. I think that would be the best option for her. And according, hello.
Actually, what the thing is that you need to treat the patient with consideration. You have to ask about need for future fertility, and you have to give her a whole bouquet. What all options does she have for treatment? And you should help her to choose the most appropriate treatment instead of putting our ideas across to the patient that, better have a myomectomy or have a hysterectomy or whatever. Whatever we are thinking for, a good informed decision has to be taken by the patient, which is only facilitated by the doctor. So this is very important, because if anything goes wrong, Dr. Geeta Goen told you examples that anything goes wrong and it bounces back on the doctor. So especially when there are no clear-cut indications, informed decision making from the patient is very, very important. Next slide, please.
I think, as ma'am said, non-directive counseling, like we need to be clear,
Yes.
give her all the options.
So what are the indications of medical management in a case of fibroid uterus? Which drugs, what is their efficiency, and what is the precautions before you start the treatment? If the patient doesn't want surgical treatment, how are you going to manage this patient? Anyone?
If the patient does not want surgery, of course, then the route will be medical management, and that will again be hormonal therapy. You give her initially, matlab, along most cases, we give a progesterone therapy with a along with a क्या बोलते हैं, hemostatic agent that can be offered. Again, we do an indication management if the patient is young, she wants to preserve fertility, she does not want to undergo fertility, does not want to undergo surgery, either conservative or definitive surgery. Those are the indications. You start with hormone therapy, you can give oral therapy.
What
And
drugs are you going to give, and what is their efficacy? What are the precautions? What are the drugs that you're giving specifically?
We routinely give progesterone therapy. Hello?
Progesterone for fibroids?
I'm specifically asking about RU486, uripristol and mifepristol.
Oh, okay. Yeah.
The
We
patient
we.
Hello.
Yeah, go ahead.
Hello.
Everybody
If
else,
patient
please
is
unmute.
having cyclical bleeding, then we can
Dr.
give
Padma?
her. Yes, ma'am.
वीडियो चालू करिए ना.
Hello.
हाँ जी.
Yes,
बताइए.
patient is having cyclical bleeding, then we can go for tranexamic acid plus mefenamic acid combination, madam. Means
Next slide, please.
Mefenamic has it reduces the bleeding, but if patient is having menometrorrhagia, then we have to we should go for hysteroscopy guided endometrial biopsy. If everything is fine, there's no endometrial hyperplasia, then we can, if she is willing, then we can go for LNG IUCD, or we can give her oral tablets, like we can keep her on RU486, or we can give her ulipristal.
Ma'am, uripristol is banned now.
Yeah,
Ulipristal is banned now.
Madam was asking, that's why I have just.
Next slide, please. Next slide, please. Would you advise uterine artery embolization for this case? She's 39 years old.
Yeah, we can go for it. If it's a fibroid, it is effective.
Ideal case. Ma'am, first thing, what we would like to do is an ultrasound guided fibroid mapping or an MRI guided fibroid mapping. If there is a single fibroid, then we could go ahead with uterine artery embolization. If there are multiple fibroids, then this probably would not work.
It would still work, you know. It would depend on you would have to do it for the major trunk. Okay. Otherwise, you just do it for the vessel supplying the fibroid. So it would still work even if it's multiple or it's single, whatever. Okay, uterine fibroid embolization or uterine artery embolization. So due to collateral circulation, the uterus will not necrose even if both the arteries are occluded. And it's not a major intervention, and the patient can be discharged after 24 hours. Next slide, please. Radiofrequency ablation ration, RFA. This has been researched. It's a minimally invasive procedure that involves inserting a needle-like device into the fibroid through the abdomen and heating it with low-frequency electrical current. It's called the Hall's method. It's currently in phase 3 clinical trials, and it still awaits approval for uterine fibroids. Next slide, please. So this is the procedure that there are 3 small incisions given, a lap camera is inserted, then an intra-abdominal ultrasound probe is inserted. Third is the device which goes into the fibroid. It's done under general anesthesia, and it can be done multiple times. And depending on how many fibroids are found, but the patient can go home the same day. And the potential downsides are similar to other minimally invasive surgeries. So this is upcoming. For a 39-year-old, this would still be an option, but still it has to be validated and allowed first. Next slide, please. Again, MRI guided focused ultrasound. Anyone has an experience of this?
No, madam.
Suvarna, madam?
Actually, there are a lot of cases being done in Jaslok Hospital. We have it available there. But somehow it has taken a backseat. It is not the procedure of choice. Only selected cases are being referred there, and only those cases which fit in their selection criteria, they are getting effective, and it's not free of side effects. So you have to take into consideration that even the side effects are known, even though we feel that it is there are injuries that can happen while the procedure is being done. But yes, but for selected cases with expertise and experience, this is one option that you can give.
Ma'am, what are the selection criteria, if you could tell for our knowledge?
No, I don't know offhand like this, but if you have any, slide, I mean, there are specific number of fibroids, size of the fibroids, location of the fibroid, where you pass the beam, it should not go through any vital organ or, any injury that may happen. So all these specifications
so basically are there. It has to be the anterior wall fibroid.
Yes. So all
it
this
has to be an anterior wall fibroid.
Defined and fitting into the indications, then only you can do, not for all patients.
Okay. Thank you, ma'am. So ultrasound can be focused by a lens, transducer, phased array, or any combination. And it's, as you said, that the ultrasound should not pass through any vital organ. So it has to be an anterior wall fibroid, and the beam has to hit it, like it's fit here on a focal plane, and there are still chances of injury to other organs. And it can be done multiple times. Next slide. The advantages are there's no scar, can be done as a day procedure, short hospital stay, least chances of infection, early resuming of daily activities, interferes least with everyday life of the woman, can be done in multiple sittings for a large size fibroid, and repeating the procedure has lowest risk as compared to surgical options. So, but as you say, these are theories, and your experience, as you have seen in patients, is really very limited, and the results equally so. Next, please. So these are the Fogsi GCPR guidelines for fibroids. Dr. Monica, you would like to take them?
Yes, ma'am. Intramural or submucosal myomas, which is grade 2 to grade 6, can be treated with tranexamic acid or combined oral contraceptive pills, NSAIDs, and levonorgestrel intrauterine device. If the treatment fails, then myomectomy, depending on the location. In women more than 40 years of age, fertility would not be considered for a small fibroid less than 4 to 5 centimeters. Then medical management followed by hysterectomy, or short-term management up to 6 months with GnRH agonist with an ADVAC therapy followed by myomectomy. The long-term management would include a levonorgestrel intrauterine system with newer medical options, the progesterone receptor modulators like uricrystal acetate or low-dose mifepristone, or submucosal myomectomy, which is grade 0 to 1, or hysteroscopic removal or abdominal removal. Now let's go.
May I make a comment? May I make a comment? I was the part of this GCPR guidelines group, and we had a meeting, and ulipristal is there because it was before it was banned.
Yes,
so please make sure that these guidelines are taken with the current happenings and the recent updates.
Yes. Let's go through the surgeries. The conservative surgeries that we can offer to a patient would include myomectomy and hysterectomy at the last option. What would be the pros and cons for a patient that we select for a laparoscopic myomectomy? Can Dr. Manisha or Dr. Anjali?
Hello, sorry to interrupt you, ma'am. I want to ask one question in this platform. That have you seen reduction in size by using MRU 486?
Yes, ma'am.
Because I have seen that patient usually they go into amenorrhea, but the size of the fibroid doesn't decrease.
And these drugs would be definitely helpful if the patient is at present not fit for surgery and you need to buy time till the time she undergoes a myomectomy. definitely
Yes,
we
ma'am.
could go ahead for a short course till she becomes fit for a surgery or till her hemoglobin improves, and then we can take her up. If
Yes,
the
ma'am.
patient is not willing to take those drugs, then you can also use GNHRH antagonist injections and then build her HB.
Ma'am, that's what I want to clear, that the size of the fibroid usually doesn't decrease even with the mifepristone.
With 3 to 4 months, ma'am, it decreases, ma'am.
Size definitely decreases. Yes.
Yes, ma'am.
Ma'am, I have not seen
Some patients it is not a significant reduction, but definitely it
Yes,
reduces. And as Dr. Monica said, it is just a phase that we are. I mean, we are buying time for before we give any definitive treatment.
The only disadvantages of using GnRH antagonists would be the capsule would not be very well differentiated at the time of myomectomy.
Myomectomy, yes.
Yes, ma'am.
Yes.
Thank you, ma'am. Thank you.
Can we have the at least
Sorry,
what
I got
patients would you
disconnected.
select for a laparoscopic myomectomy?
Uh,
And what principles would you follow for the same?
I think the most obvious one, the selection would be a young age and the patient who wants to preserve the uterus and wants to preserve fertility. That will be your case. In this particular case, since she's had an umbilical hernia repair, then you have to consider that. That might make the surgery a bit more challenging. The principle, of course, what we routinely do is we use vasopressin to reduce the blood supply, create the plane, and to remove the fibroid. It will be easier. She'll get the most benefit. It's not been mentioned if she has a single fibroid or multiple fibroid. So it will be we'll do a fibroid mapping before the procedure. That would probably what we would do in this case. Sometimes also it becomes a cosmetic issue as well, because if she's a thin patient and it's a 14 to 16 weeks uterus, so she might want the fibroid removal for that reason also, if she's not responding to medical management.
Hello? Hello? Am I audible?
Yes, ma'am.
Is there any role for a hysteroscopic myomectomy in this patient if it was a submucosal fibroid?
Yes, definitely. The guidelines really are very good. The Fogsi GCPR, I think they've specified also like less than 3 centimeter hysteroscopic myomectomy will definitely be beneficial in this particular case.
Can I ask what are the other recent drugs that have been available or what is under trial as medical management of fibroid other than RE486, if anybody can throw light upon? The non-hormonal therapies. Swarna, ma'am?
Sorry, I'm taking my medicines.
Yes, sure.
Yes, what is the question?
Ma'am, are there any other non-hormonal treatments which have been recently approved for treatment of fibroids other than using mifepristone?
I have no idea. Actually, I've not read up and come. I've just come offhand. So can you only enlighten all of us?
There have been studies where letrozole also has been used, ma'am, in some cases. And there is another drug. They said vitamin D also helps in reduction in the size of fibroids given for 3 to 6 months. And there is a drug which has been recently released. It acts both on the estrogen and progesterone receptors, and it targets the catecholamine O-methyl transferase and the transforming growth factor beta. And they said that it has to be taken as 1 capsule BID for at least 3 to 6 months, and there is a reduction in 30 to 40% of the size of the fibroid. This could be a promising therapy where we are using vitamin D, epigalacin galatate, and triglutrin Y4D. These are the herbal non-hormonal contents of those drugs.
I think role of vitamin D in fibroids is very well recognized. So, and in whether fibroids or no fibroids, I think vitamin D has to be supplemented to all women.
If we are going for a hysterectomy, then what would be the route and why for this patient?
I think total laparoscopic hysterectomy would be better, madam, for this patient, because she has already got hernia repair. So one more thing which is very important, she's previous 2 sections plus hernioplasty. So whether mesh was used or not, that is also important. And during hernioplasty. And by laparoscopic hysterectomy, we can give supra-umbilical by the supra-umbilical port, we can go for the laparoscopic hysterectomy. That is much more easier, I think. In vaginal hysterectomy, there will be more chances of bladder injury because there could be adhesions.
We're talking about this patient who has previous 2 cesarean sections also now.
Yes, ma'am.
With
That's what.
hernia, so vaginal would not be a very good option for her.
Yes, ma'am.
Varna ma'am, can you please conclude the case, ma'am? Asha ma'am? Ma'am, we are on the last slide. Can we please conclude this case, ma'am?
I think you all have taken excellent cases and all difficult ones and all thought-provoking, and all the panelists have really done very well and they have discussed out all the options. But one thing I noticed, nowadays the balloon therapy is completely gone out of picture. I mean, nobody's and I am so much fond of balloon therapies. We have used in so many cases, and we have been using pressure balloon therapy for abnormal uterine bleeding, not like such a case where but when we have such a high risk patient who has undergone 3 surgeries and she's not willing for operation, surgeon is not willing for her to take the 4th surgery on.
Yes,
And so if such a case, it's worth trying pressure balloon therapy. I don't know if you have heard about Shivkar balloon, which we practiced in JJ hospital since 1980s. So that we used first for PPH. The same balloon we started using for abnormal uterine bleeding in gynec cases, and it has given excellent result. So even such patients, we always give a try with this, and many of them do improve with simple pressure balloon therapy, and it is quite useful. So I'm wondering why nobody talks about the balloon therapies, or even those so many devices. They have therma choice and things like that have now no more being discussed also, because I think this Mirena has completely taken over the market, you can say, and it is almost every patient is I won't say every patient, but at least 70-75% patients are happy with it. And those who don't want to undergo hysterectomy, they definitely opt for this type of method.
So, Varna madam, may I ask you a simple question?
Yeah.
You
but
said
answer
pressure
may
therapy.
Be difficult. Answer may be
pressure therapy, madam. Do you think it would cause endometriosis? See, adenomyosis or endometriosis, because you're giving pressure and
it's
the
not
it's
not active pressure that we give. It's the gravitational pressure which we give with a saline which is held at 60 centimeters from her her table where she's lying. We insert the balloon inside the uterus and we keep the saline bottle and we maintain that pressure, low pressure, long hours. It's not that with the Foley's bulb some people use, they inject Foley's balloon, that is with force. So then that risk would be there. Okay, and when you are injecting the inflating the balloon near the scar, that risk is also there that it may just rupture that scar when you are expanding the this thing. So that is out of risk. So that is why it is designed in such a way that it is with the least possible complication.
It came to my head, so I asked you. Thanks a lot for.
But answer was simple. I thought your simple question may be a complicated answer.
No. Thank you, ma'am. Thank you so much. So, a hysterectomy, abdominal, vaginal, LAVH, or TLH? What do you say?
Are you asking me?
All of you. You last. So, madam, last. Okay. You last. So, my panelists, respected panelists, please Which one and why? Dr. Padma?
Madam, total laparoscopic hysterectomy from my side. I would like to do total laparoscopic hysterectomy.
Dr. Anshu?
Yeah, I think, sorry, I think what happened to my video stop. I think, yeah, if you have the expertise, a laparoscopic hysterectomy is the way to go. A vaginal would definitely be very difficult in this case. And I don't know with the boom that laparoscopy has, nobody is really doing an abdominal hysterectomy. And also you will, since he has previous 2 sections, you will be expecting a lot of adhesion, so there'll be a better visualization laparoscopically. But yes, in either case, she'll be a very challenging case to operate, considering her previous 3 surgeries and
Dr. Richa? Dr. Richa? People have logged off mostly. Anjali, madam?
Madam, probably laparoscopic assisted vaginal hysterectomy.
Okay. And could you say why?
Because you have all the benefits, you are visualizing the things. So you are at less for injury. And I think the controls will also be there with vaginal hysterectomy also. So probably I would like to go ahead with LAVH.
So at the end, Suvarna,
ma'am, can I add a line, ma'am, please?
Yes.
Ma'am, it would definitely depend upon the expertise of the operating surgeon.
Yes, there is no doubt about it.
Only if there is a possibility that we have a helping hand for laparoscopy, and if you have that expertise, then we could go ahead. Otherwise, a total abdominal hysterectomy would also suffice for.
So basically, I think there are 3 things. What does the patient want? What are the facilities available? And what is the payment status? Because if she is from Ayushman Yojana or something, it would not be really feasible for you to do it at that rate when you're doing a TLH. So on the ground level, all 3 factors would have to be taken into consideration. So Suvarna madam, if you would like to sum up, please now.
Yeah, I think Dr. Monica said what I wanted to say. It largely depends on the expertise of the surgeon. So if the case goes to somebody like Dr. Shirish Sheth, he will do it vaginal hysterectomy beautifully. If it goes to expert laparoscopic surgeons, they may even do total laparoscopic hysterectomy. And somebody like, nowadays most people are proficient in doing laparoscopic assisted vaginal hysterectomy. That seems to be the better option here. And the total abdominal hysterectomy, however, even if you want to do, you should not proceed in this case, because I think there is a incisional hernia repair that has already been done. So you don't want to disturb that. So it is better to take other options. If you don't feel good enough to go with a laparoscopy, refer the patient somewhere where laparoscopic assisted vaginal hysterectomy can be done.
Absolutely.
Thank you, ma'am. Thank you.
Thank you so much.
Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
I would like to thank Suvarna ma'am for her expert comments in this panel, and Dr. Asha Jain as well to allow me to moderate along with you, ma'am.
Oh, it was your panel, my dear.
No, ma'am.
So my pleasure to be with you.
Thank you, ma'am. I would like to thank Dr.
Thank
Kalyan
you,
Baramke
everyone.
and Priyanka for giving us this opportunity. Thank you so much, all the panelists, for your active inputs.
Thank you. Good night.
Yeah.
Thank you, ma'am.
That was indeed an excellent panel, beautiful discussion, beautifully moderated by Dr. Asha Jain ma'am and Dr. Monica. And of course, very nice comments from our panelists, and of course the expert, Dr. Suvarna Khadilkar ma'am. That was in fact very, very nicely done and thoroughly enjoyed. I just like to share a screen once, because nowadays some numbers seem to be little unreal, and that is why I wanted to show this to everyone here. So this is at the end of our day, and I'm so sorry. And this is what our attendance looks like. So we had 1,300 delegates from India. And if you put together the other countries, so it was almost 1,350 plus delegates from across the globe. So again, I would like to mention this thing, that meeting is only what the faculties are. So beautifully done, our expert faculties today. And so thank everyone. I would like to invite Dr. Kalyan Barmade, the chairperson of the committee.
It is so nice to see my teacher, Dr. P.K. Shah, still logged in and
Yes.
hearing So you rightly said he is teacher of teachers.
Nice
Thank
one.
you so much, sir.
Thank you, Shah. So we
Thank
are
you
so
from-
honored to have you here, right
Yeah,
to
sure.
the end.
Yeah, very good.
Namaskar,
Very
sir.
well conducted.
Thank you.
Very well conducted.
Thank you, sir. Thank you
you so
from
much,
MP Society.
On behalf of Public Awareness Committee of Fogsi and office bearers of Fogsi, I really thank all OBGYN societies of MP and Chhattisgarh, all presidents, secretaries for attending this webinar. I'm really thankful to my teacher of teachers, Dr. P.K. Shah sir, for guiding us. And the most important is, though chief guest, he is listening to everyone and giving remarks till the end. That is what a teacher is, true teacher is there. I'd like to thank Dr. Jyoti Bindal ma'am, Dr. Rosa ma'am, and Dr. Archana Baser for being a guest of honors. I'm really thankful to both speakers, Dr. Jaideep Tank and Dr. Geeta ma'am, for giving their topics. And I'm really thankful to all panelists, panel moderators, and all experts for this webinar. I'm really thankful from bottom of heart, and all the delegates, around 1.3 thousand who are attending this webinar. And at the last, I'd like to thank our support partner academic, Corona, and their support staff for helping us for this webinar. And the last word, I'm really thankful to Dr. Priyankur for conducting this webinar so nicely. And I wish all the best for his upcoming chairperson elections. I'm very sure he's going to be the next chair of PAC. Thank you so much. So good night from Public Awareness Committee for all. See you after 15 days with other societies from South India.
Thank you so much, sir.
Thank you, everyone. Thank you, Dr. Priyankur.
Thank you. It's a pleasure. Thank you so much.
Thank you, Priyanka. Thank you.
Bye. Hello, Geeta.
PK sir,
Hi,
thank you so
hi.
much, sir.
अरे बस काय
काय खूप छान, शेवटपर्यंत कोणीच थांबत नाही.
Hello.
Thank you, sir. Thank you for
very well conducted. Priyankur,
Priyankur is
all the
good.
best.
Thank you, sir. Thank you,
Yeah,
sir. Thank you, sir.
it was a mini conference.
Hello.
Quarter to 4 hours.
Can you just stop the YouTube sharing, please?